3:15, it is on the clock. The subcommittee will come to order. The chair now recognizes himself for 5 minutes for an opening statement. Today, we're here to critically examine two proposed regulations from the Biden administration that threaten to disrupt care for millions of seniors and people with disabilities throughout the country. The proposed minimum staffing rule would require nursing homes to have a minimum number of registered nurses and nurse aides, while the Medicaid access rule would require home health agencies to pass through a minimum of 80% of all payments to the direct care workforce. While well-intentioned, these rules are misguided and will ultimately threaten to undermine access to vital services that our most vulnerable rely upon. The success of our long-term care system is integral to the success of the broader health care system. Caregivers are the backbone of our long-term health care system, providing around-the-clock care and oftentimes undertaking physically intensive work to support our loved ones. We're at a critical juncture for our long-term health care system. Since the start of the pandemic, we've lost hundreds of thousands of workers from nursing homes, as well as home and community-based services. Nationally, there have been more than 500 long-term care facility closures since 2020, and the industry needs to fill 150,000 jobs just to reach pre-pandemic levels, while Americans continue to age and need more long-term care. More needs to be done. However, instead of partnering with Congress, the Biden administration is embracing central planning, claiming their proposal will lead to more workers being hired and help ensure safety. Unfortunately, this is far from reality. These one-size-fits-all, Washington knows best approaches will impose unfunded mandates on states and providers with reducing overall access to vital services without addressing the root cause of the problem. Regarding the minimum staffing standards, analysis from the Kaiser Family Foundation found that as many as 80% of nursing homes would not be able to meet its requirements. Separate analysis found that the mandate will cost Kentucky long-term care facilities $69 million annually just to come into compliance. Even the Obama administration agreed about the harms of racial requirements, concluding in 2016 that this policy would stifle innovation and wouldn't improve quality and lead to the elimination of jobs. I had a long-term care administrator in Barron County say our rural area in South Central Kentucky simply does not have access to additional workers. The lack of providers that will result from this requirement will result in no options for long-term care services. The Glasgow and Barron County market has 5 nursing homes and an acute care hospital competing for the same registered nurses. America's seniors and future generations deserve solutions that will increase access to affordable, high-quality health care. I will continue to work as the chair of this subcommittee toward achieving those objectives. I will submit the full statement. I just read excerpts from my full statement for the record, but I will yield to my friend, Mr. Pence from Indiana.
Thank you, Chair Guthrie, for yielding time. I'm deeply concerned with the Biden administration's proposal to mandate minimum nursing staff ratios. It's something I've really focused on this subcommittee in the whole duration I've been on it. I recently sent a bipartisan letter to CMS with more than 90 of my colleagues on both sides of the aisle to oppose this prospective policy, in addition to the letter I sent on March 10th. Finalizing this HHS proposal would result in limited access to care for seniors, mandatory increases in state Medicaid budgets, and could most consequentially lead to widespread nursing home closures. Nursing homes around the country would need to hire nearly 13,000 more registered nurses and 76,000 nursing assistants. I'm on a community college and we have a nursing program. We can't even get the trainers to fill the demand of people that want to become nurses, let alone get nurses out into the communities. CMS one-size-fits-all regulatory requirement for nursing homes would result in numerous unintended consequences for an industry that is facing workforce shortages at unprecedented levels, particularly in rural communities. CMS should instead collaborate and work alongside nursing homes across the country to find innovative solutions to improve the provision of care for seniors and other vulnerable populations. I look forward to hearing from all the witnesses here today as they explain how this proposed rule would impact their ability to serve new and existing residents across the country. And, Mr. Chair, I yield back.
The gentleman yields back, and I will yield back my time, but submit my full statement, yield back my time. I now recognize the gentlelady from California, Rep. SU, for 5 minutes for an opening statement.
Thank you, Mr. Chairman, and it's with relief that I left the floor with many of you and the election of the new speaker, so it's good to be back in business, and Godspeed. May he be successful so that there's success for the country. In a Gallup poll conducted last month, 70% of Americans said they were uncomfortable with the idea of living in a nursing home. When asked to grade the overall quality of care in nursing homes, Americans gave the facilities an average grade of D+. These dismal marks, most frankly, I'm not surprised by them, because I don't know anyone that raises their hand and said, I'd be happy to go to a nursing home. It represents many different things to a whole cross-section of people. We know that during COVID, over 200,000 nursing home residents died of the virus between January 20th and February of 22. So in a 2-year period, almost 250,000 Americans. Even before the pandemic, nursing homes faced quality issues. And if there's anyone that is famous for associating himself with the shortcomings in the nursing home industry, it's Senator Chuck Grassley. He's conducted so many investigations, and of course there are GAO and HHS Inspector General reports that I think that colleagues on both sides of the aisle are very familiar with. Now the Biden administration has proposed what they view as a solution to the lack of staff providing care in nursing homes. Red light and siren. Hire more people. It's as simple as that. We've all, I think, been in a hospital or a healthcare setting where there's a button. And when we press that button, we want someone to come to us. Does it cost something? Of course it does. Of course it does. But if no one comes when you press the button, things go downhill from there. So the proposed rule requires a registered nurse to be on site 24 hours a day, 7 days a week, instead of the current minimum of only 8 straight hours a day. The rule also requires 1 registered nurse for every 44 residents and 1 nurse aide for every 10 residents. The rule phases in for most facilities over 3 years, but gives rural facilities 5 years to come into compliance. It also provides $75 million in grants to train nurse aides. The inability of nursing homes to hire and keep staff has been a problem for over 30 years. This isn't something new. According to the National Academies of Health, quote, decades of evidence support the need to enhance nursing home workers' training, salary, and working conditions, yet little progress has been made to improve the quality of these jobs. I know that we want to get to our witnesses because we're going to be called for votes, and it's unfair to you, the witnesses that have traveled from different parts of the country to get here. I hope out of this debate and discussion that it goes beyond bashing the Biden administration. There are real issues with nursing homes in our countries. I'm proud to have worked with nursing home people to make improvements over the years. But there are still many shortcomings, And I think for those that will end up in a nursing home, and God knows, it may be many of us here making these decisions today. When we press the button, we want someone to come, and they need to be well-trained, and that the people that they are serving can be served. I have a constituent. She's a quadriplegic. She depends on home-based services for daily activities. It's next to impossible for her to find a place that can give her the kind of care that she needs. We can do much better in this country. I was going to yield back time, and I've gone over the time.
Thank you.
Thank you, Mr. Chairman.
Thank you. The gentlelady yields back. The chair recognizes the chair of the full committee, Chair Rodgers, for 5 minutes for an opening statement.
I'd like to thank our witnesses for being here today. As many of you know, our son Cole was born with that extra 21st chromosome. Most of you know it as Down syndrome. And today, Cole is a 16-year-old. He's a high school student with big dreams. He wants to be a football player or a coach, a pastor, a race car driver, and he's dreaming of going to college. For people with disabilities like Cole, others born with intellectual and developmental disabilities, or even seniors facing physical limitations in their everyday lives, the sky is truly the limit to their potential. Long-term care services and supports, whether that be those provided by home and community-based services, or HCBS for short, or in nursing home settings, are key to ensuring that people can live successful and independent lives. As many of us know, there is a shortage of long-term care providers. Since 2020, we've lost tens of thousands of workers across both HCBS and nursing home settings as workers left the field due to burnout or in pursuit of other opportunities. While these stressors were present in the long-term care field prior to the pandemic, they've gotten worse. Even as other parts of the healthcare field began to return to pre-pandemic employment levels, the future of care for seniors and people with disabilities depends on us finding a way to support long-term care workers. I've been troubled by recent proposals from the Biden administration that, while they may be well-intentioned, I am concerned are going to further undermine this workforce. The administration proposed the so-called Medicaid access rule, which would require home health agencies to pass through a minimum of 80% of all reimbursements directly to the direct care workforce. State Medicaid directors and advocates, however, have raised concerns, stating that such a high threshold is out of reach for most agencies and would require agencies to have to reduce service and staff to be able to ensure that they comply with the rule. Put simply, this proposal would actively undermine access to care, running counter to the very name of the rule. Additionally, just last month, the administration followed the access rule with a proposal to require minimum staffing levels for nursing homes. Like the access rule, this minimum staffing rule is setting unrealistic staffing thresholds. Independent analysis have found that as many as 80% of all nursing homes, 80% of all nursing homes will not be able to meet the requirements of the rule, meaning that facilities are going to have to increase costs even further, reduce censuses, and stop accepting new residents, or potentially even close. We all believe in access to high-quality care, but proposed requirements that are untenable for 4 out of 5 nursing homes do not represent a serious solution. And those who rely on skilled nursing care deserve better than a proposal that will dramatically reduce their care. These top-down approaches are not the way forward in supporting seniors and people with disabilities. And it's my hope today that we will begin a conversation on ways that we can find more meaningful solutions to help those in need. We cannot let this rule simply go into effect and watch idly as individuals with disabilities and seniors lose the support they need to maintain their independence. We do not want to see people forced into hospitals for chronic conditions that could have been avoided. You know, I often say this, I am proud of the bipartisan work of this committee, from passing Lower Cost, More Transparency Act, to making healthcare more affordable and accessible, to reauthorizing Mr. Guthrie's Support Act to help those struggling with substance use disorder. And I'll note that my colleague, Mr. Pence, has just led a bipartisan letter to the administration with over 90 members raising concerns with the nursing home staffing rule. I hope in the spirit of bipartisanship we can discuss these policies and find a pathway forward that helps people with disabilities and seniors get the access and the care that they need. I yield back.
Gentlelady yields back. The chair yields back. The chair will now recognize the ranking member of the full committee, Mr. Pallone, for 5 minutes for questions, for opening statement.
Thank you, Mr. Chairman. Today's hearing is important. Quite frankly, it deserves thoughtful consideration and discussion, not being shoved in between the ongoing Republican efforts to elect a speaker that has repeatedly caused committee activity to be delayed for hours on end over the last 3 weeks. Due to all of this uncertainty, we were not able to include a witness who had been considering, we have been considering, who is quadriplegic and receives insurance through Medicaid. Travel is understandably challenging for him as he needs to make sure it works not just for his schedule, but also for his personal care worker. Unfortunately, given the unpredictability, we were not able to guarantee that this witness would be able to make his return flight. Of course, there would be less of an issue if the Republicans still allowed us to have witnesses join virtually, which we don't have under the current Republican procedures. And that restriction on virtual hearings or virtual witnesses is preventing important voices from being heard at our hearings, including this hearing today. But I want to say that the COVID-19 pandemic laid bare what many of us have known for years. There is a staffing crisis in our long-term care infrastructure. Chronic understaffing threatens patient safety, access to care, and contributes to provider burnout. During the pandemic, nearly 1 in 4 COVID-19 deaths occurred in a long-term care facility, and understaffed facilities were more than twice as likely early in the pandemic to have COVID-19 infections as comparable facilities with higher staffing levels. And this is tragic, and that's why last Congress I introduced comprehensive legislation that would increase staffing and oversight of nursing homes in an effort to prevent a situation like what we witnessed during the pandemic. Now, I'm pleased the Biden administration has taken steps to help address staffing issues in both nursing homes and home-based settings. Research continues to show that higher nursing home staffing levels are associated with better patient outcomes. If we want to improve the quality of care people receive in nursing homes, we need to ensure there are enough qualified workers there to care for them. The administration's proposed rules would take steps to do just that. They establish minimum staffing standards for nursing homes, require that at least 80% of Medicaid payments for home care services go through caregiver pay, and expand nursing home oversight. These proposed rules are strong first steps to help ensure that patients in nursing homes and home and community-based settings are able to get the care that they need. And these are important improvements that must be made, but I understand that it may take some facilities more time than others to come into compliance. Fortunately, the proposed rule already includes flexibility for certain facilities. It allows for an exception for facilities in areas where workforce shortages, if they're making a good faith to hire additional staff, do not have a history of safety violations. The administration is also proposing to phase in the rules requirements gradually with additional time for rural nursing homes. So I'm glad the administration is serious about taking steps to improve patient safety and safety conditions, while also recognizing the unique challenges some nursing homes may face in complying with the new rules. I look forward to hearing our witnesses' perspectives on the rule and to working with all of you and with the administration to ensure that it's successfully implemented. And I yield back, Mr. Chairman.
Thank you. The gentleman yields back. That concludes our opening statements, and we'll go to witnesses' opening statements. I introduce all of you, and then when I call on you, you'll have 5 minutes. I think most of you testified before. If you haven't, then there'll be a warning light, a yellow light with a minute after 4 minutes, a minute to go, and that's when to start wrapping up your. So we're trying to get everybody in and questions in. So I'll move straight to introducing our witnesses. First, we have Sheriff Schuman, Vice President of Operations for Brookside Inn. Mary Killau, Vice President of Operations and Government Relations at Accent Care. Shelley Hughes, Certified Nurse Aide. Lori Smetanka, did I say that correctly, Mustanka, Executive Director, the National Consumer Voice for Quality Long-Term Care. Patty Killingsworth, former Chair of LTSS, TennCare, Chief Strategy Officer, CareBridge Health. So thank you, and Ms. Schuman, you're recognized for 5 minutes for your opening statement.
Thank you, Chair Guthrie, Ranking Member Eshoo, Ranking Member Pallone, and the members of the Subcommittee of Health. Thank you for giving me the opportunity to testify today. My name is Sarah Schuman, and I'm the operator of Brookside Inn and Brookside Rehabilitation in Castle Rock, Colorado, just south of Denver. I'm here to talk to you about the long-term care workforce and how the recently proposed staffing mandate from the Centers for Medicare and Medicaid Services will have dangerous consequences, specifically limiting access to care for our most vulnerable. I'm a second-generation nursing home operator. My father, a physician, founded our organization. I grew up in a multi-generational household, and we had the privilege to serve 3 of my grandparents who eventually lived and passed in our communities. My mother, my grandmother, 3 of my great-grandparents, and numerous aunts were all licensed registered nurses. Inspired by the nurturing of these women, I chose to become a chaplain and a certified nursing assistant. My life has been blessed with a deep love for our elders and profound admiration of nurses. Having dedicated my adult life to seniors in long-term care, I can say without a doubt that this is more than just a job. That's why the current workforce challenges and the looming federal staffing mandate are heartbreaking and terrifying. We are still in recovery mode from the challenges of the pandemic. Our staff are true heroes. Nursing homes are facing a historic labor shortage, and the proposed staffing mandate will only make things worse. Colorado is one of the fastest growing elderly populations, but like the rest of our nation, our caregiver workforce cannot keep pace. We are doing everything we can to recruit more caregivers, but there are significant obstacles. All of our local healthcare providers are recruiting nurses as well. To attract more workers, Brookside has increased our wages by more than 40% in almost all caregiver positions. We have increased our benefits package. But even with the higher pay and better incentives, we are still facing hiring challenges simply because the number of qualified caregivers that we need are not there. Unfortunately, at times we have had to turn to costly staffing agencies. I am concerned the staffing mandate would have the unintended consequence of increasing the use of agency staff. That is not the best solution for quality of care for our residents, and it's financially unsustainable. In one of our facilities, 85% of our residents rely on Medicaid. A recent analysis of the staffing mandate found that facilities with a higher Medicaid census were less likely to meet the proposed requirements. Again, I am concerned that the administration does not realize the unintended consequences of this policy and how it will disproportionately impact underprivileged seniors and underserved communities. Like most of the profession, Wall Street does not own my company. We serve residents on Medicaid, and we do not have the resources to fund this unfunded mandate. I am terrified we would be unable to continue serving seniors in our community. We are not alone in this fear. Nearly 300,000 nursing home residents nationwide could be displaced and left scrambling for alternative care if this mandate proceeds. In 2016, prior to the pandemic, I began my quest to Congress asking for workforce relief. We entered the pandemic with staffing challenges, and those challenges have persisted. We cannot be expected to just magically grow new caregivers. Instead of an impossible mandate, something that 94% of nursing homes, mine included, cannot currently meet, we should be implementing solutions together, such as workforce recruitment programs, student loan forgiveness, and tax credits for those choosing to work in our profession. And we should be investing in our nursing schools and learning institutions to help build a pipeline of caregivers for a growing elderly population. The caregivers in our nursing homes care deeply for our beloved residents. The work we do is sacred. This is one of the most compassionate and selfless professions in the world, and we need your support. As I wrap up my time with you, I'd like to ask the committee, is there a way we can work together to create supportive policies that will actually make a difference in the lives of our seniors and our long-term care staff? How can we together serve our precious elders? How can we collaborate to support our nursing professionals? Can we together create solutions to develop a much-needed workforce for skilled nursing communities? Thank you.
Thank you. The gentlelady yields back. The chair will now recognize Ms. Killow for 5 minutes for opening statement.
Thank you. Ranking Member Pallone, Chairman Guthrie, Ranking Member Ashu, and the members of the Energy and Commerce Health Subcommittee, thank you for the invitation to testify today and the opportunity to provide insight into issues related to direct care workforce and access to Medicaid, home and community-based services. My name is Mary Killow, and I serve as Vice President of Operations for Accent Care Personal Care Services in Illinois. Our agency started operating in 1984 and employs over 2,100 home care aides who provide home and community-based services to over 2,900 older adults and individuals with disabilities in their homes. As a leader of HCBS Home Health and Hospice Services, Accent Care serves the entire home care continuum, consistently delivering high-quality care for our patients and program participants. In addition to providing HCBS services in Illinois, Accent Care employs over 15,000 direct care workers who deliver over 15 million hours of care annually in Arizona, New York, and Texas. Since graduating from law school, I have spent the last 30 years working to protect and care for older adults and individuals with disabilities. As a Cook County State's Attorney, I prosecuted cases against individuals who victimize seniors and persons with disabilities. As the Deputy Director of the Illinois Department on Aging, I served under 2 governors and managed the agency that directed and implemented most aspects of aging policy and planning throughout the entire state, including the largest waiver, the aging waiver. And then now, as a senior leader at one of the largest provider of home and community-based services in Chicagoland, I am fortunate enough to work along dedicated colleagues like Ella Grays and home care aides that have been with the agency that I work at for over 2 decades. The direct care workforce is in crisis, and it will require a wide range of policy, programmatic changes to meet the current and future demands of HCBS. Unfortunately, the administration's proposal mandated that HCBS providers pass through 80% of Medicaid payments to direct care workers will not achieve the desired objective of increasing access to services or expanding the workforce. In fact, it would have the opposite effect. As I addressed in my written testimony, if CMS finalizes the proposed one-size-fits-all federally mandated wage threshold, the likely outcome would be that home care provider will close and providers reducing their service areas, with these impacts being most felt for the smaller agencies or rural providers that serve participants from racial and ethnic minority groups. Accent Care fully supports higher wages for the direct care workforce, and we've been actively advocating in our 4 operating states for higher payment rates with the purpose of increasing home care aid wages. The administration's proposal does not address the primary issue that has been suppressing direct care workers' wages, and that is the historically underfunded provider payments, the very payments that allow us to provide wages to our direct care workforce. States are making investments to increase payments to support HCPS and the direct care workers who provide the services. The overly prescriptive 80% wage pass-through requirement would jeopardize that progress. In fact, we note that many states, including those making those historic investments, such as Texas, have expressed concerns with the proposal. We must not undercut efforts to expand HCBS workforce, increase wages, and improve quality of life for workers and program participants. Solutions to the workforce shortage will require home care providers, state and federal policymakers, key stakeholders to thoughtfully examine not only the wages and benefits provided, but the myriad of issues that have been identified over the past decades that are limiting employment growth of direct care workforce. Ensuring access to long-term care services within Medicaid program will require a comprehensive approach with a wide range of policy reforms, while maintaining the state's flexibility as prescribed under the Medicaid Act. My colleagues at Accent Care and I welcome the opportunity to work with the committee, the administration, and a broad group of stakeholders to provide a pathway to increase access to home care and services, and to maximize direct care worker wages. By working together, we can solve this issue. Thank you so much.
Thank you, Ms. Kello. The chair now recognizes Ms. Hughes for 5 minutes for her opening statement.
Thank you, members of the subcommittee, for inviting me to speak today. My name is Shelley Hughes, and I am a certified nurse's aide at a nursing home in Bellingham, Washington, and a proud member of SCIU Local 775. I speak before you on behalf of the millions of nursing home workers across the country whose lives depend on the choices and actions of our lawmakers. We need safe staffing now. That is not an opinion, that is a fact. We have one united thesis. Our long-term care system is on the verge of collapsing, and short staffing is the catalyst. A strong federal minimum staffing standard is the best way to rectify the devastating and deadly consequences of this crisis. CMS has proposed such a standard, and it is imperative that we strengthen, implement, and enforce this rule to the fullest extent. If anything good came out of the COVID-19 pandemic, it was being finally forced to confront the dire straits nursing homes are in. Unfortunately, it took a global pandemic and the deaths of 200,000 nursing home residents and workers for the public to see how severe the staffing crisis is. But these issues are not new. Our population is rapidly aging, and plenty of people want to do this work, So why is CNA turnover at nearly 100%? Poverty wages, a lack of benefits and training opportunities, and so much more have made the nursing home jobs we love nearly impossible to do. But short staffing tops that list. All of our residents have unique needs and require specialized care. Tasks that take only a few minutes for you or me could take my residents 45 minutes. You have to move at their individual pace, but when you're working short-staffed, you often don't have that luxury. I often work nights, 9 p.m. to 9 a.m., but the urgency of care doesn't set with the sun. Because of short staffing, I regularly work as one of 2 CNAs for 60 residents in our long-term care unit. That means 30 residents per CNA. How can you care for 30 individuals in just 12 hours? Short staffing forces CNAs to make impossible, painful choices every day. What would you do in this scenario? You're the only CNA on the floor for 30 residents, and Mr. Smith is ready for his bath. You've gotten Mr. Smith undressed and are helping him into the tub. Suddenly, a few rooms down, you hear a bang and Mrs. Jones calling for help. Do you leave Mr. Smith naked and alone in the bathroom? Or do you run to Mrs. Jones, who may have fallen and injured herself? All the while, Mr. Johnson down the hall is urinated in bed and is laying in soiled clothes and sheets. Who do you help first? I cannot describe the heartbreak CNAs experience when we'd have to tell a resident, I can't, or not now, or when we don't have time to speak with them at all. I've dedicated my life to this work, but because of short staffing, I often feel helpless and defeated. Sometimes I get in my car and sob because my residents were robbed of the quality care and time I promised to give them. We are stuck in an existential loop where low staffing leads to even more low staffing. A federal minimum staffing standard can end this cycle. Nursing home residents are living, breathing people with fears and passions and ambitions. Their needs change daily and unexpectedly. We are seeing more and more residents with mental health needs which require a total sea change in how a facility operates. Taking care of residents with complex needs requires an advanced skill set and enough staff to perform the necessary tasks. As it is, we don't have the training or the staff to adapt to this new reality. Residents cannot receive high-quality care without a minimum number of CNAs. We are the fuel that runs the engine in our nursing homes. We want to bring quality care to these facilities. We want residents and families to feel secure and well cared for. Workers need a seat at the table to have more transparency with our employers. A federal minimum staffing standard would hold nursing home owners accountable for what happens in their facilities and would ensure public funding for nursing homes goes to the bedside and not into pocketbooks. We've called for help for decades. We hear over and over that decision makers are committed to taking action. When our elected leaders and employers say we're in this together, we want to trust that they mean it. But increased funding and resources are dangled before us like a carrot on a stick. Right now, we have an opportunity to end this dangerous game. A strong federal minimum staffing standard for nursing homes is the best action we can take to move toward a long-term care system that provides dignified care to those that need it, that attracts, retains, and sufficiently compensates a professional workforce. Only then can we meet the challenges we face in the coming decades. Thank you.
Thank you. Thank you for your testimony. Ms. Mustanka, you are now recognized for 5 minutes for your opening statement.
Chairman Guthrie, Ranking Member Eshoo, distinguished members of the committee, thank you for holding this important hearing. The National Consumer Voice for Quality Long-Term Care works with and on behalf of long-term care consumers and their families. Most of us will need care and support during our lifetime. Whether provided at home or in a long-term care setting, nursing staff must be available to provide quality care. The proposed nursing home minimum staffing and HCBS access rules are designed to help ensure that there are adequate nursing staff to meet the needs of care recipients while also improving access to care. Inadequate staffing in nursing homes is a decades-old problem, resulting in basic care being omitted, long delays, and harm to both residents and workers. The current federal requirement for sufficient staff to meet resident needs has been inadequately implemented and enforced. Thus, staffing levels vary widely in facilities. The impact of short staffing is disturbing. Residents being left in bed over entire weekends, twice-a-week showers being reduced to weekly, yet still often missed, residents eating alone in their rooms because not enough staff can help transport them to the dining room, and waiting more than an hour for help to go to the bathroom, that help not coming, and sitting in soiled clothes until someone finally arrives. One resident talked about her neighbor who, having a medical emergency, called for help, yet died when no one responded after nearly 45 minutes. Staff also tell us about being responsible for 15, 20, or more residents per shift and having to make difficult choices regarding whose needs are going to wait or if they're going to be met at all. One resident told us, understaffing means you don't get cleaned or changed, which leaves you susceptible to all kinds of sicknesses, and that's counterintuitive to how you're supposed to live in a nursing home. You're not supposed to get sicker here because of low staffing. 22 years after a CMS-sponsored comprehensive study identified minimum levels of licensed nurse and nurse aide time necessary to prevent harm to residents, most nursing homes still do not meet this basic staffing level because it's never been required or enforced. It is possible, however, to meet recommended staffing levels. Data shows that thousands of homes do it every day. These are primarily nonprofit nursing homes, and they provide about 43 minutes more staff time each day than the average for-profit home. The location of these facilities, rural versus urban, is not a factor. It's not that facilities can't staff to recommended levels. It's that they choose not to. The benefits to residents of higher staffing are indisputable. Higher levels improve quality care. Most homes that are highly rated in all 5-star categories provide at least 4.1 hours per resident day of care. As staffing levels decrease, so do star ratings. Most troubling, as staffing levels decrease, the likelihood of a home being cited for resident abuse increases significantly. Each year, tens of billions of public dollars are paid to the nursing home industry, yet the outcomes of many homes are unacceptable. A review of Medicare cost reports and a look into the widespread industry use of related party transactions raise critical questions about how Medicaid and Medicare dollars are spent, whether the money goes towards care or profit. For the safety and well-being of residents, there must be better transparency and accountability for how nursing homes spend the money they receive. A staffing standard is simply a mechanism to ensure that public dollars go towards direct care. Achieving quality care requires developing and supporting the long-term care workforce. This includes ensuring a living wage, skills training, career ladders, and quality jobs. To the extent that there are workforce shortages in communities, efforts to promote recruitment and retention of staff must be a priority. It is not an excuse, however, for accepting substandard care for beneficiaries. The proposed HCBS access rule also seeks to increase access to in-home support services by requiring the 80% of Medicaid payments go towards worker compensation and requiring additional reporting and transparency. These proposed rules, when finalized, will create better jobs, reduce turnover, and increase access to home and community-based services. Calls to inhibit the rules are unjustifiable. Residents and home care consumers are going without needed care and services. The proposed rules will help move us in the right direction. Now is the time to ensure that beneficiaries have access to necessary staff and good care. Thank you.
Thank you. Thank you for your testimony. The chair now recognizes Ms. Killingsworth for 5 minutes for your opening statement.
Thank you, Chairman Guthrie and distinguished members of the committee. My name is Patty Killingsworth. I'm a lifelong family caregiver with more than 25 years of Medicaid experience, most of that in long-term services and supports. I currently serve as a commissioner on the Medicaid and CHIP Payment and Access Commission and Chief Strategy Officer for CareBridge Health, but offer my testimony today based on my personal and professional experience and my commitment to those we serve. The national shortage of the direct workforce is the greatest challenge that face LTSS programs today. My written testimony provides context regarding the longstanding and intractable nature of the problem and its impacts. So I'll focus my oral testimony on the need for a comprehensive workforce strategy, why the proposed regulations fall short of meeting that need, and the critical importance of workforce alternatives to increase personal independence and improve quality of life while helping mitigate the impacts of the workforce shortage on access to care. The direct workforce that supports individuals receiving LTSS is a common one, with aides working across long-term services and settings to deliver care. This means that any policy actions taken either by Congress or by CMS must be considered in light of the broader impact on the LTSS system, including nursing facility and HCBS programs, populations, and providers. Minimum staffing standards relative to nursing home care should not be established without due consideration of the impact of such policies on the much larger number of people receiving or waiting to receive HCBS. CMS should not perpetuate or exacerbate longstanding institutional biases in the Medicaid statute through workforce policies that drive a greater share of a limited direct workforce, as well as LTSS expenditures away from community and to the institution. Congress should instead take long overdue actions to remedy these institutional biases and assure equitable access to LTSS for Americans in the setting of their choice, while supporting states' efforts to rebalance their LTSS systems and comply with the integration mandate of the ADA. While the pass-through percentage for HCBS payments is well-intentioned, it has fundamental flaws described in my written testimony and will not ensure that the Medicaid payment is adequate, including the payment to the worker. We need a more thoughtful, data-driven approach that seeks to understand what constitutes an adequate payment for these services, how it should be appropriately allocated between the wages of direct care workers and other essential indirect employer and agency costs, and how this can be accomplished in a way that does not favor institutional care. Pay is one of a set of key elements of a comprehensive workforce strategy that includes uniform federal minimum training requirements with demonstration of competency, career pathways across secondary schools and post-secondary institutions, expanded scope of practice to encompass medication administration and routine healthcare tasks, elevating the role with commensurate increases in pay, and focusing an also limited nursing workforce on more complex skilled nursing functions, and a common approach for both nursing homes and HCBS to ensure the adequacy of Medicaid payment and funding to the workforce, including transparent, accountable reporting of Medicaid LTSS payments and costs, a data-informed approach to ensure payment adequacy based on analysis of a minimum of 2 years of payment and cost data, a consistent policy approach across nursing facility and all HCBS programs, providers, and populations that share a common workforce and workforce challenges, an enhanced FFP for state investments and increased payments to workers delivering services in more cost-effective HCBS settings, either as a state plan option or an MFP-like demonstration. We must also recognize that the overwhelming challenges will not be solved by workforce solutions alone, and adopt person-centered approaches that prioritize and support independence and optimize the use of limited workforce resources through the expanded use of assistive technology and other alternative support options. To that end, Congress should embed independence as a key goal of HCBS throughout all applicable sections of Title 19, require that person-centered planning identify individualized goals for employment, independence, employment, and inclusion, and prioritize assistive technologies that will maximize their opportunities to achieve those goals. Require that Medicaid HCBS are structured to ensure streamlined access to technologies and services that increase independence and offer a more cost-efficient way of meeting support needs, and require a standardized and accountable system of measuring effectiveness and supporting people to achieve valued outcomes, with streamlined authority mechanisms and supports to states to implement value-based payments that are aligned with those outcomes. Technology will never be able to replace the high-value in-person care that so many individuals need, so a comprehensive workforce strategy remains critical. But for many older adults and people with disabilities, it offers a significant opportunity to help ensure reliable assistance that they need to live safe, meaningful lives in the community with increased independence and improved quality of life. And in a world where the gap between workforce demand and supply is growing, it may well mean the difference between people living in an institution and living in the community with a level of independence that makes life worth living. Thank you very much.
Thank you. Thank you for your testimony. That concludes witness opening statements, and we'll now turn to members' questions. And well, I'll begin. I reckon myself for 5 minutes for questions. So, Ms. Schuman, we're looking at, you have to absolutely consider safety first. You have to have access and affordability, and you certainly don't want to compromise safety to get access and affordability, nor do you want to make it more expensive and less affordability if you don't improve safety. So I just want to ask you a couple of questions. One, in regard to the proposed nursing staff ratio requirements, can you walk us through the very realities you would face if it were finalized? And could you comply without cutting positions or limiting the number of Medicare residents? And do you have the local supply of labor to meet those needs?
Thank you, Chair Guthrie, and thank you so much for the support you've given our profession during this challenging time with workforce issues. We greatly appreciate it. Currently, my communities would not be able to meet the RN requirement, the 24-hour-7 requirement, and the CNA requirement. And in fact, Chairman, in the state of Colorado, we have had a 24/7 requirement for many years, and for the past 2 years, it has been waived in our state because our state realizes that there's not an availability of RNs. We have recruited my historic numbers, my RN hours during this pandemic have gone down 60%, not by choice, but because they are not available.
Actually have a bill, the Building America's Healthcare Workforce Act, that will provide temporary nurse aides with the ability to work in long-term care facilities beyond the 4 months. And when that was implemented during COVID because we needed more workers, and so that was a problem. We had to improve access. And when it was asked, I looked at it and said, maybe we should extend this in a permanent way. My first question was, is there any case anywhere in the country that anybody was negatively affected because of that proposal? And if there is one, I don't know it, or nobody reported to that as well. But I want to ask you this. Part of the reason the Biden administration is focused on this, we talked about safety first, is that of the prevalence of COVID-19 cases in long-term care facilities. Is there any evidence to show that staffing ratios, we know we had issues in long-term care facilities. Is there any evidence to show that staffing ratios are equated to higher COVID case counts in any facility?
Not to my knowledge, Chairman.
Okay, thank you. So, Ms. Killingsworth, major policy changes, especially those that pass costs on to states and local governments as well as private businesses, should be based on quality data. Are you aware of any data CMS provided to support the 80-20 formula?
I don't believe that there is publicly available data that could be used to draw a conclusion that that's the appropriate level of reimbursement to pass through to the frontline workforce.
So we don't know of any data they provided us.
I do not.
For. Also, do you think that this one-size-fits-all approach makes sense for diverse geographic areas with differing workforces?
Not only does it not make sense for diverse geographic areas, it doesn't really even make sense for the workforce because in practice, the amount that gets passed through even across different populations and programs will differ for the same workforce delivering essentially the same service.
Okay, and can you provide examples of how states have been attempting to address worker pay using the flexibility afforded by the Medicaid statute? And how would CMS's rule proposal undo some of the progress individual states have made in trying to bring more people into the workforce?
I think the majority of states use the enhanced funding provided through the American Rescue Plan Act to at least do temporary, if not permanent, increases in wages for staff. They're also doing many things to invest in training for staff, to promote recruitment and retention, more of a comprehensive approach. Unfortunately, I think a mandate will require a shift in attention and in focus to really meeting the terms of that mandate in ways that will undermine the work that states are currently doing.
Okay, thank you. I will yield back a minute of time and trying to keep it going and moving forward, and I will recognize my friend from California, Ms. Eshu, for 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to each one of the witnesses. You gave very important testimony, and we appreciate it. This is an issue that I think we don't ever want to face up to, really, in a family until it happens, you know, and like so many issues here in the Congress, this is about money. It's all about money. It really is all about money. If anyone doesn't think so, you just scratch a little from the top layer like a scratcher, you know, and it's about money. Now, according to MacPac, nursing homes receive over $66 billion from the Medicaid program alone. About 1.3 million Americans live in nursing homes. What is the typical wage for nursing aides in a nursing home? Why don't we start with you, Ms. Schuman? What's the typical wage for a nursing aide?
Thank you, Ranking Member. It does depend, of course, on locality. My starting wage for a nurse aide is $23 an hour, plus shift differentials, plus benefits, including full paid insurance and insurance for their children for health, medical, dental, and 3.5 weeks a year of paid time off.
Now, in your testimony, you noted that your nursing home increased wages by more than 40% in all caregiver positions. What were the wages before you increased them 40%?
Our wages were 18. The increase in 40% also includes overtime and additional benefits
So it was $18 an hour before that.
with shift differentials.
And Ms. Hughes, what's the story with where you work?
Where I work in Washington, we've recently gotten the floor for CNAs up to $20 an hour. There are some facilities that are offering similar wages, 22, 23, 24. A lot of those increases happened during the pandemic. Before that, our starting wages looked more like $16, $17.
And as the wages went up, were there fewer people to fill those positions? Or
Eventually,
did it solidify the workforce and say,
It
well,
helped
at
to
least now,
stabilize.
we're getting paid more?
it helped to stabilize the workforce. I can remember personally begging people just to hold on until, we got a new contract negotiated, because it seemed like there was going to be some new money available for raises. So in my facility, yeah, we were able to hang on to workers a little bit better than some of the surrounding facilities.
So there was an increase, are most of the patients Medicaid where you work?
Yes, in our long-term care unit, most of those people
And
are.
Emma
Medicaid.
Schuman, what about your place?
One of our
I admire
communities.
the tradition in your family of nursing and care. Are the majority of your patients, your clients, Medicaid?
Thank you. In one of our communities, it is 85%, so yes.
85% Medicaid. Well, I think that if we want a level of care that we can be proud of, and have anyone from any of our relatives in a place of care, people need to be paid. I don't think anyone that's working in this industry is demanding that their demands are off the charts. But unless you have enough people being paid, and you've increased, which is very good, they simply, you know what it does for where there are fewer, in my view, fewer caregivers, even if their pay has gone up, if there aren't enough, it degrades the level of work that those workers can do. I raised 2 children. Some days, they're 18 months apart, I thought I had 10 children in terms of their demands. Now, I'm not saying every patient is a child, but it takes a lot. I took care of my mother and father. I took care of them, and it takes a great deal to take good care of them. So I don't know about the rest of the members. I think it's very important, and I know it cuts into profits, and that's the issue. But we need a sustained workforce that they work hard. They earn this pay. And if we're not committed to the standards, we have no standards right now, unless we have good people like you that have a pride in their own business. What is the standard? It's one word. Sufficient. What the hell is sufficient? Who can define it? It's like nailing Jell-O to a wall. So there isn't any way that can be enforced. So we need strong standards and the right kind of pay and a trained workforce to take care of those that are in our nursing homes. Thank you, Mr. Chairman.
Thanks. The gentlelady yields back. The chair recognizes the chair of the full committee, Ms. Rodgers, for 5 minutes for questions.
Thank you, Mr. Chairman. We've all had family members that have have been in some of these facilities. Certainly my family has, and we share the absolute commitment to standards, to a well-trained and paid workforce. I note that in Spokane, Washington right now, Sacred Heart needs 300 nurses. 300 nurses at Sacred Heart Hospital. So the idea that it's just a money issue, I'm not. When you don't have the people, how are you supposed to find these people? I'm also a mom with a son, a who has Down syndrome. I know firsthand what it means to care for a family member who has a disability. And Cole succeeds in school and life, thanks to his own tenacity, his strength, but also support from his family, his friends, his teachers. And there's countless of Americans with disabilities who rely on services that are provided to them. Mrs. Killau, I wanted to ask you about the 80-20 pass-through rule, because these individuals with disabilities are counting on the services that you provide to make sure that they can be successful and independent in their lives. So just, would you speak to the implications of the proposed 80-20 pass-through rule on people with disabilities?
Thank you for the opportunity to speak on this. If this pass-through goes through, it would cause, first of all, it would cause a sufficient rate. We can't pay what we don't receive as far as a provider rate. We cannot pay out wages unless we get a sufficient rate on behalf of the state to be able to pay these wages. If we do not get a rate of pay, what would happen is that it'll undercut other aspects. If 80% goes out to the direct care workforce, the other 20%, which we must use to handle administrative costs, facilities, training, supervision. It's nice to have a workforce out in the home, but if you don't have adequate supervision, your quality goes down. Those issues will remain in effect. And the smaller organizations, it's an economy of scale. The smaller organizations cannot deal with that 80% pass-through.
Thank you for that insight. Mrs. Schuman, I don't believe that there's a one-size-fits-all solution to the workforce shortage. Everywhere we go, we're hearing about the workforce shortage. And the needs of the people in Eastern Washington differ from that in Seattle, which differs from other people across the country, maybe New Jersey. The state of Washington does have a law requiring nursing homes have enough staff to provide for over 3 hours of care per resident per day. This is about on par for the total number of hours that the proposed rule would require. However, our state's law does not delineate who has to provide this care. It could be from registered nurses, nurse aides, or licensed practical nurses. The federal proposal, however, would require a minimum of half an hour's worth of support be provided by a registered nurse and the rest be provided by a nurse aide, and it would exclude licensed practical nurses entirely from the standard. Can you speak to the challenges of such a rigid requirement that dictates the facilities, the specifics of a facility, and how they be staffed?
Thank you, Chairwoman. I think it's an unfortunate oversight that this proposed mandate excludes LPNs. In our community, we have several individuals who have gone a career path and become CNAs to LPNs. LPNs bring a much-needed diversity to our community. They work in tandem with registered nurses and physicians and CNAs to provide outcomes of care. In addition, social workers are not recognized in this mandate. Activities personnel are not recognized in this mandate. Physical therapy, occupational therapy, none of the other modalities that we provide in our profession have been recognized by this mandate.
Okay, thank you. Ms. Killingsworth, I wanted to ask you, because we hear a lot about what's not going right. We don't have enough workers, too many regulations, not enough money to go around. In spite of this, we do have states that are making progress on addressing these shortages. So would you maybe give us some insights into what states and plans are doing to address these challenges and what opportunities we may have to support them?
Thank you, Chairwoman. It's an important thing for us to understand is that money may be one part of a solution, but it's not the entirety of the solution. This is a complex issue that will require a comprehensive approach. I think states that are making progress have been very strategic in that approach. They have combined training programs with career ladders that really draw people into the field. They are doing more to support workforce recruitment and retention. They are doing more to elevate the social value and role to really enhance the work that workforce is able to provide in ways that then draw a higher salary for the workforce. So there are opportunities to make progress, but as a practical matter, we are at a place in this country where we do not have enough people to deliver all of the supports that individuals need, and you can't regulate or buy your way out of that problem.
Thank you. Thank you all for being here and what you do. I yield back.
Thank you. And now we're kind of even with the ranking member and chair, so we're going to try to stick to 5 minutes. We can get as many questions as we can before vote. So, Mr. Pallone, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Republicans claim that the rules under discussion today are an unfunded mandate, but last Congress, when Democrats on this committee voted to provide states with a substantial increase in federal dollars to invest in the home and community-based services and the HCBS workforce, Republicans stood in opposition. Meanwhile, they've offered no policy proposals of their own other than weakening regulations. Greater federal investment in long-term care services shouldn't be controversial. In fact, the testimony of the Republicans' own witness, Ms. Killingworth, suggests greater federal investment in these services is needed. And our seniors and caregivers deserve better, in my opinion. We owe it to them to ensure that they're able to age and be cared for with dignity and compassion, that they have access to the care that they need when they need it. And the Biden administration's proposed regulations would be a strong step in that direction. So I'd like to ask some of the witnesses to address some of the claims that we've heard today. Let me ask first Ms. Smetanka. You've heard testimony that there aren't workers available to meet the minimum staffing standards. Could you respond to that claim?
Yes, thank you, Congressman. Well, part of the issue is in some communities there may be challenges with identifying workers, but a big part of the problem also is turnover among staff that are in long-term care facilities right now. In nursing homes, the turnover rates range between 50 and 100% based on the research that you look at and the data that you're looking at. If you can't keep staff, that is going to be a problem when you're needing to continue to fill positions with new people. So a really important part of this issue is talking about how we need to reduce the turnover, how we need to improve job quality and conditions for workers so that they're wanting to stay in these facilities and stay in this field.
Now, according to your testimony, not-for-profit nursing homes seem to generally have higher staffing levels than for-profit nursing homes. Can you explain why you believe that's the case?
Yes, the data showed, this is CMS's data that showed staffing levels in nonprofit versus profit nursing homes. And it does show that they staff at nearly 43 minutes more per day for residents than for-profit homes. And the only thing that we can attribute that to is they put more resources into direct staff. They're putting more money into it.
I appreciate that. I just want to make sure that we're focused on patient and caregiver safety. So let me ask you also, how do minimum staffing standards in nursing homes impact on the quality of life experienced by residents in those nursing homes?
What we found is that there need to be a minimum threshold below which you can't go in order to provide care for residents, in order to meet the basic needs of residents. The studies show, the data show that the more staff you have, the higher the quality care, the better outcomes for individual residents. By having the staff on hand, not only are they meeting basic needs of residents, they get to know the residents, they spend time with them, they recognize triggers, they recognize preferences and goals of those individuals. They're able to actually sit and provide the additional care that those individuals need. They're able to identify much more quickly changes in condition, and they're able to then also respond to issues that they may need if they need to redirect a resident who may be in distress or may be having outbursts of some kind. They're better able to respond to the needs of that individual person and to provide the person-centered care, which ultimately improves not only quality of life, but quality of care for those people.
Well, thank you. Now, let me just ask one question of Ms. Hughes. Your testimony is particularly harrowing. You describe a situation where low staffing levels perpetuate low staffing levels. Can you talk a little about what you meant by that?
Absolutely. We don't seem to have a problem with recruitment in my field of work. I know this from talking to caregivers in nursing homes all across the country. It's the same thing. New people come in knowing full well what to expect. They know exactly what the pay is. They know the sort of things they will be doing in a nursing home, but what no one tells them is that the ratios will make it impossible to give decent care. It's not the low wages, it's not the backbreaking labor, it is the heartbreak that I see chase more, fresh-faced new people away than anything else. When you are low-staffed, you end up working more to try and fill those holes. That leads to burnout, which leads to call-offs, which leads to more short staffing. it's this perpetual cycle. And the only way to get out of it is just to put more people on the floor to care for our residents.
Thank you so much. Thank you, Mr. Chairman.
Thank you. The gentleman yields back. The chair recognizes Dr. Burgess for 5 minutes.
Thank you, Mr. Chairman. Let me start by asking unanimous consent to include 3 letters into the record, one from the co-chair of the House Doctors Caucus, one from Creative Solutions in Healthcare, and one from the Texas Association for Home Care and Hospice. Thank you. Ms. Killingsworth, let me just ask you, when this hearing was noticed, I got significant feedback from providers in my area, the home care and hospice folks. There's obviously a lot of concern of what the 80-20 rule requirement is going to do to their business. Every state has different requirements and different rates at which they pay. Texas is probably on the low end of the average. But can you talk a little bit about the data methodology that CMS is using to make these determinations? What is CMS including in that 80%?
So I'm not sure that I can actually speak to exactly what all CMS included in the 80%. I think that there is a need for greater definition as to what exactly is included in that 80%. I think, as you point out, it will pose significant challenges for providers, especially if that 80% is narrowly defined and it does not take into account activities that are really necessary to support retention of workers, things like training and other kinds of support that are really important for the workforce. So really clear definitions are a part of what would be needed in order to enact a regulation. But I will say again, the question is really, will the regulation solve the problem, right? Or will it create greater challenges than the challenges that we're facing today and have create even more access issues for people? And I think that's true for both of the regulations.
Well, let me just tell you some of the pushback I've received on this. I have a congressional district that's sort of halfway in between the more populated eastern part of the state and the sparsely populated western part of the state. So some home care nurses have to travel a great deal. Their patients are, of course, we don't want the patients in the hospital. We want to take care of them at home as long as possible. But they've got to travel a long distance. My understanding is that their mileage calculation is not included in the 80% that's allowable by CMS.
Yes, sir, that is my understanding as well, and agree would be a particular burden on rural providers.
So is there anything else that's not included in the 80% that you feel that your practitioners have to account for?
I think there have been many comments submitted on the regulations which really highlight a number of things that have been omitted from the 80%, again, along with just a lack of clarity in terms of what all is encompassed within the 80%. But I'll say again, that it is the threshold itself, along with the lack of clear definition as to what should be included or excluded, that is problematic.
Ms. Schuman, let me ask you a question. You mentioned about licensed practice, and thank you for your answer. Licensed practical nurses, what reason has the agency given you that they will not reimburse for licensed practical nurses, or that they can't be included in this?
Thank you for your question, Representative. I don't know the reason why it was not included, but I can tell you that they are licensed nurses. They are licensed.
And I've worked with many. I'm a physician. I've worked with many over the years. I will also say this is a practical matter. State budgets right now are doing okay, but I will also tell you, as someone who's provided Medicaid services for 25 years back in Texas, when state budgets get tight, Medicaid reimbursements is one of the first things that feels that squeeze. So it's another area where we need to be concerned. Ms. Killow, let me just ask you, on the turnover rate side, how do you think this new rule is going to affect things on the turnover rate?
with regards to home and community-based services,
Yes.
with regards to the pass-through, the 80% pass-through rule with regards to direct workforce will not increase the workforce with regards to adding additional people in the workforce. We do not believe it'll have that impact.
I've got some additional questions. I'll submit for the record. Thank you, Mr. Chairman.
Thank you. The gentleman yields back. Chair recognizes Mr. Sarbanes for 5 minutes for questions.
Thank you very much, Mr. Chairman. Thanks to all our panelists, particularly Ms. Hughes. I want to thank you for your work and the work of your colleagues. You don't get enough recognition. I think you're part of, in a sense, a hidden workforce that makes the world go round. And I have a special appreciation of this because in the last year of my father's life, he was in a nursing home setting, and I saw what a difference it made to him to have the right kind of care. And it was during the pandemic, so we only got to see him twice in that final year in person. And that was outside in a parking lot. But the nurses that attended to him were our heroes, and you represent them today. And you've talked about how stretched thin that workforce is and how you have to strike a balance in terms of the care that residents need and what you can provide under the circumstances that you face. We know we're facing significant workforce shortages across the healthcare workforce, some driven by the pandemic, others were exacerbated by it. Can you speak to, I mean, you've done it already, but maybe you could speak again to how challenging it's been for you and other caregivers to have to take the care of up to 30 residents sometimes per shift, and what that effect is on both the patient's well-being and the caregiver's well-being. I mean, what does it mean to be pulled in all those different directions? And I think you spoke to how demoralizing it is if you're someone who wants to provide care, but just can't because you're being pulled in so many directions.
Absolutely. There are good days and there are bad days. When things are working the way that they're supposed to, my job is wonderful. I love my job. When we have enough staff, I actually have the time I need to spend with my residents, to talk with them, to provide the care to the level that is required. But on the days when we are staff challenged, because we're not allowed to say short-staffed, anything could happen. If you have someone, I work at night, and that tends to be when residents with dementia and Alzheimer's have their greatest difficulty. The only way to properly care for them and keep them safe is one-on-one attention. You can't leave them alone. Bad things could happen. But if you're one of only 2 aides to take care of 50, 60 residents, how do you do that? How do you sit with Mr. Johnson to keep him from screaming or keep him from wandering from the facility because he's looking for his wife? He doesn't remember that she's been gone for 20 years. You can't tell him that. You have to go into their world. It's such an intimate experience. There's no way to provide that kind of care when you're pulled in multiple different directions. I'm happy to do it. We're all happy to do this work, but we need to be given the tools in order to do it properly.
I appreciate that, and I remembered the different times a day when residents, patients become particularly agitated and need that kind of extra attention. It makes all the difference in the world. And, you know, I understand there's a chicken and egg dynamic here. There's a tension, right? Because there is such a tremendous shortage out there. So people worry about, you know, if you just set a standard, you're like putting your head in the sand against that reality. But my view is that there needs to be a standard to drive everything else that we need to do. So let's set that standard, which is what I think the Biden administration is trying to do. and figure out how to meet it. Because if we meet it, we're doing right, not just by you and your colleagues, but as you just so powerfully described, we're doing right by the people that we want to receive that care. And by the way, if they're in good hands, we also know that positive sense and comfort and assurance cascades out to a whole extended family. And if the opposite is true, it has a negative and anxiety-creating impact on that family. So that's why it's so important.
Thank you.
Thank you.
Thank you, gentlemen. Time has expired. The chair now recognizes Mr. Johnson from Ohio for 5 minutes.
Well, thank you, Chairman Guthrie, and good afternoon to our panelists. Thank you all for joining us today. But, you know, here we are, exposing yet another damaging rule proposed by this administration that'll put folks out of business if enacted. I have grave concerns over the provision in the proposed rule ensuring access to Medicaid services that would require states to mandate at least 80% of Medicaid payments for home and community-based services be spent on compensation to direct care workers. I think they should be compensated, don't get me wrong. I don't know how a business in rural Appalachia that is dependent almost solely on Medicaid patients would be able to survive that kind of deal. Just this week, I heard from one of those in Youngstown, Ohio. Their opinion of this 80-20 rule proposal was clear. If I have to pay 80%, I'll be out of business. What's also clear is the authors of this rule at CMS have never signed the front side of a paycheck. They've never actually run the companies that they're trying to regulate. If 80% of Medicaid reimbursement is to go to compensation, then that remaining 20%, only 20%, is meant to cover everything else, from insurance and legal fees to facility upkeep, operations, maintenance, and administrative costs. Energy costs alone, given the administration's dedication to ensuring that Americans pay more at the pump and to heat their homes, means folks like this home health provider will either stop serving the Medicaid community or close their doors entirely. I would hope that this is not the intention of the Biden administration. And let me be clear, I think everyone, again, I want to say this, I think everyone in this room wants to see the highest possible level of care provided, and to do that, staff must be properly compensated. But this rule is not the solution to that issue. So, Ms. Killingsworth, let's assume the 80-20 rule is finalized. If a state like Ohio determined that they had to raise reimbursement rates to ensure they had sufficient providers to serve recipients, but didn't have approval from the state legislature to increase the overall program funding, what other changes would have to be made to keep spending level? How would those changes impact access for patients?
Thank you for the question. State Medicaid programs basically have 3 levers to help them manage costs within a program budget. One of those is who you serve, another is the benefits you provide, and the third is what you pay providers to deliver those services. If one of those is mandated to increase substantially without approved resources to cover, that means one of the other 2 must be reduced, which means fewer people served or fewer benefits provided to those individuals.
So basically, somebody's going to lose out in this deal if that were to go through, okay? Mr. Chair, I have a request that I have here an article from the Home Care Association of America that outlines state home care based services concerns about this proposed rule. I request that be entered into the record.
I have no objection. So ordered.
One way to ease the burden on staff while increasing efficiency and outcomes for patients would be increasing the adoption of electronic health records. Studies of EHRs, that's what they're called, found they enhance productivity and efficiency in primary care physician workloads. And a study of nurses in nursing homes published in the Journal of Applied Gerontology found that the majority of respondents evaluated the electronic health record as easy to use with a positive impact on quality of care through efficiencies gained in communication with the entire care team. Ms. Schuman, in your opinion, would wider adoption of integrated electronic health records in nursing homes beyond the 18% that currently have these systems, would that ease some of the staffing shortages nursing homes are facing?
Thank you for your question, Representative. We have had electronic medical records fully implemented in my community for 10 years. It does improve efficiencies.
But would wider adoption help with this?
It does improve efficiencies with communication with physicians or your colleagues.
Okay, what about savings? What about from a savings perspective? Would the adoption of electronic health records be a cost-effective approach to improving quality of care and reducing workforce burdens for nursing homes?
Considering the regulations that we have and all the T's we need to cross and I's we need to dot, having electronic medical records does provide some ease with all the documentation that we need to maintain.
Okay, all right. Well, thank you very much. Mr. Chairman, I yield back.
Gentleman yields back. The chair recognizes Mr. Cardenas for 5 minutes for questions.
Thank you, Chair Guthrie and Ranking Member Eshoo, for holding this hearing to discuss long-term care workforce shortages. And I also want to thank you to the witnesses for sharing your expertise and your personal knowledge of the day-to-day workings of this very, very important issue where we're trying to take care of people in this country. I know my colleagues hear about workforce shortages issues on a nearly daily basis, as we should be listening to what is going out there in our communities. These issues pose a massive threat to our ability to provide quality health care to all people who need it. And when it comes to our seniors and individuals with disabilities, we must recognize these are greater vulnerabilities than the general population. The share of the U.S. population aged 65 and older has more than doubled over the past 50 years. And now we are scrambling to ensure we have a pipeline of healthcare workers who will do this essential, often dangerous and grueling work, or leave our grandparents and loved ones without support that they need. The Bureau of Labor Statistics estimates that a projected overall demand for long-term services and support workers will grow by 44% between 2020 and 2035. The demand of these essential workers is clear, and as the need for the services grows, the workforce is only declining. Wages for these roles remain low and burnout remains high. And as our population ages, we must build the resilience and longevity of the direct care workforce, which leads me to my first question. Mrs. Smetanka, in your testimony, you emphasized that development and support for the long-term care workforce is a critical component for achieving quality long-term care and services. What kind of support is most essential for the long-term care workforce, and can you expand on how these rules will impact quality of care?
Well, yes, thank you, Congressman, for your question. We do need to put more attention on how we recruit and retain workers in this country. That is a definite. Putting proposals in place to attract people to these jobs is really critical. One aspect of what these rules would do to help attract workers to the field is to make these jobs better so that people actually want to come and work in long-term care facilities and make them places where people will want to stay. As my co-testifier here, Ms. Hughes, stated, part of the problem with attracting and retaining the workforce is job quality. That's an enormous part of it. And people who do not want to come and have overburdened work options in front of them, they need to be able to know that they're coming to a job where they're going to have a reasonable workload, they're going to have the supports necessary, the training necessary to provide the care to the individuals in front of them. And part of that is having enough staff available in order to be able to spend the time and provide the care and services to residents. And that's what these minimum staffing levels will do.
Thank you. I also want to note that in my home state of California, 60% of the direct care workforce was estimated to be women of color. And at the national level, foreign-born workers make up about 25% of the direct care workers in the home care industry and about 19% of direct care workers in the nursing home care industry. Ms. Smetanka, can you expand on what recruitment efforts typically entail for these types of roles, and why is there such a disproportionate reliance on immigrant labor in this industry?
Well, I think the fact that these jobs have offered low wages and benefits, I think, again, heavy workloads, they've been jobs that have been very difficult to recruit for in many instances because, again, people don't want to overburden themselves with the jobs that they have, which is why we need more support. And frankly, whether it's a US-born worker or an immigrant worker or whomever, we all deserve quality jobs. And so we need to focus on improving the quality of the jobs in order to help reduce turnover and to recruit more people that want to work in this field.
Thank you, Ms. Hughes. I don't have much time, so I'm going to try to make this question quick. Do you know of any fellow workers who work a full-time job and/or overtime and still have the need for public assistance, whether it be childcare or food assistance or some other assistance to get by on a daily, weekly, monthly basis?
Absolutely. I myself, up until last year, qualified for our state Medicaid program.
And you worked full-time?
Yes.
Okay. My time having expired, I yield back, Mr. Chairman.
Thank you. The gentleman yields back. The chair recognizes Mr. Pence for 5 minutes.
Thank you, Chair Guthrie and Ranking Member Eshoo, for holding this meeting. I normally don't do this, but I'm going to go way off the reservation because the chairman gave me a little extra time. And thank you all for being here today. I'd like to submit for the record, Mr. Chairman, the following document from the American Hospital Association outlining the impact this rule would have on workforce shortages across a continuum of care. Highlighted in that proposed rule is the fact that according to the Bureau of Labor Statistics, there are roughly 236,000 fewer health care staff in nursing homes and other long care facilities compared to 3 years ago, which you all know, right? A report commissioned by the CMS analyzing a minimum nursing staffing requirement found that quality and safety thresholds could increase a modest 1 percentage point while costing between $1.5 to $6.8 billion to fully implement. The administration would provide $75 million for training, and that seems woefully inadequate. And as the ranking member said, it is all about the money. I understand that. And I have spent a lot of time on this. I led that letter. I appreciate everything you've done. As Cathy McMorris Rodgers said, I have also cared for family in my home and had, when we got to the point we could no longer do that, even after trying to bring in help, we had to go to a plan B. So I personally know what it's like. And then, as I mentioned in my opening statement, I'm on a community college that we're trying to train nurses, and we don't have enough teachers to train them because being a traveling nurse pays $90 an hour. In the Indiana University, you can't go that high on the scale. You can't pay somebody $4,000 a week to be a college professor, and 8 to 5 isn't quite as interesting as what many of the staff can do, flexible hours on their own. So here's a real simple question. I'm not going to get into the weeds on that, and I'm going to ask each one of you, starting with Ms. Schuman, do you think there's enough staff out there to fill the shortages that the 236,000 people? Are there enough folks out there that are trained?
Thank you, Representative. In my experience, they are not, and I would humbly request that we collaborate together to develop a workforce because this problem is not going away.
I agree. I do not think there's enough out there with regards to a workforce that's available, and we'll have to look at other areas such as family members and other people to be part of the workforce to care for people in their homes.
I would have to disagree. I think that potentially there are. Like I said, in my line of work, we see plenty of people come in and then walk right back out because the job isn't what they thought it would be.
That are trained. I want to
Yes,
be
that are trained.
understand. Okay.
Absolutely.
Okay.
I think that more needs to be done to enhance training and recruitment, but I think that there are people out there that want to work in this field and want.
Yeah, I'll kind of get to that, and I'm not trying to be pushy in the question, but are there trained staff out there now? That's really my question.
Well, I would have to defer to
Okay.
my colleague, Ms.
Okay.
Hughes, to say if there actually are today.
Okay.
I do not believe, and I believe the data supports, that there are not enough people to be able to deliver all of the services that are
Yeah,
needed.
forget about what anyone wants to do and increase the number of staff members. So real quick, is there adequate education institutes? Yes or no?
No.
We train, so I'm going to say yes.
Okay, you do it yourself.
Probably.
Okay.
Yes.
I'm sorry, I didn't understand the question.
Are there adequate education institutions to train the staff that's needed currently, and we know we have a deficit, or will be available to train the future need?
No, not based on what's
Okay.
really needed.
Thank you, Mr. Chair. I yield back.
Gentleman yields back. Chair recognizes Dr. Reese for 5 minutes for questions.
Thank you, Mr. Chairman. With an aging population in the United States, the importance of strong long-term care workforce and reliable long-term care facilities like nursing homes cannot be understated. Our seniors rely on these vital services for the care that they need to maintain a healthy quality of life. Many nursing homes struggle to hire, but more importantly, retain the number of registered nurses, RNs, and nurse aides, CNAs, needed to safely and appropriately care for all of their residents. When we look at why we are seeing this workforce shortage, two issues come to light. One is staffing levels, or nurse-to-resident ratios, and the pay rate for nurses and CNA. The nurse-to-resident ratio at many nursing homes is unsustainable. When nurses or nurse aides are responsible for caring for too many patients at once, staff all too often experience burnout, which leads to turnover, and mind you, oftentimes errors, medical errors. When burnout occurs, vulnerable residents can fall through the cracks because the nurse or nurse aide cannot be everywhere at once. And let's talk about another factor contributing to high turnover in a weakened long-term care workforce, and that's pay. CNAs do the grunt work and provide the hands-on care residents need for everyday tasks like bathing and using the restroom. This is difficult but essential work, but CNAs are paid low wages that lead them to look elsewhere in the job market. They are undervalued and underpaid, and this makes it difficult for facilities to retain staff. Ms. Hughes, you described in your testimony examples of the negative outcomes that occur for residents of long-term care facilities when nurses and nurse aides are tasked with caring for too many residents at once. What is your ideal patient to resident to CNA ratio?
Let's see. For our long-term care unit, we have about 60 residents. I think that we should never have fewer than 6 CNAs. That would be 10 residents per CNA. And we really need to have at least 3 nurses, and anything above that.
So one nurse to 10 residents?
1 CNA. Yes,
One CNA to 10
certified nurse.
residents. How much is it now?
That should be the maximum.
How much is it now on average?
On a very bad day, it could be twice. It could be twice
1 to
that. You could
20?
have 20 residents, and at nights, when we're short-staffed, you could have 30 residents. And if it's an absolute crisis, you're the only one there to take care of 60 people.
Based on your experience, Ms. Hughes, what can caregiver agencies do to improve your experience as a CNA? And what do you need from an employer to be satisfied and remain on the job as a CNA?
Well, if we're talking about, brand new recruits, people who have taken the classes and have passed the test, I think that there should be a longer period of time for them to be trained. We sort of put people right on the floor, right out of the classes, and they may have never done any sort of work like this before. So there is a very steep learning curve, and I believe that that is responsible for our high turnover rate. If we could give people an easier time onboarding into this job and never give them 10 residents, never give them 20 residents, not for the first year that they're working this job, but that would require us to put so many more aides on the floor.
So a better onboarding with training and incremental growth and the responsibility would be helpful to relieve the immediate shock of being thrown into a situation where they're caring for 30 residents at the very beginning. Is that what?
Absolutely.
Okay.
And, being able to work with experienced people makes a big difference.
Okay, so, I've been talking about these issues in the context of long-term care facilities like nursing homes. But let's not forget the importance of home and community-based services in the long-term care sector. In-home care programs can be vital to the health and well-being of patients and can provide a much higher quality of life for certain patients and better health outcomes. But quite simply, the best way we can address the challenges we have discussed today is to fund the government so that critical programs essential to the long-term care sectors remain funded and able to do the critical work our seniors and other patients needing long-term care depend on and on them to do. So we have a few days, and so I implore with my Republican Congress to let's get the job done and keep the government open so that everyday Americans can benefit. And with that, I yield back.
Gentleman's time has expired. Before I call the next part, there is a vote on the floor. There's only one vote, so if you've seen some shuffling here, we've had some rotating. So we're going to try to get people to go vote and come back so we can try to keep this going. So I know y'all have spent a lot of time here today, so we're trying to make that happen. I will recognize Pharmacy, but Dr. Harshberger for 5 minutes.
Thank you, Mr. Chairman. Thank you, ladies, for being here. And I want you to know that I've heard from dozens of healthcare providers from East Tennessee about how these two proposed rules would be devastating to their ability to deliver and provide quality care to seniors, people with disabilities. And I and many of my colleagues recently signed on to letters to CMS and HHS urging those agencies to reconsider their approach to both the proposed 80/20 rule and the proposed minimum staffing mandate rule. And Mrs. Killingsworth, first I want to thank you for being here because you are an accomplished healthcare expert from the volunteer state, so thank you for coming up. I'm worried about the domino effects that these two rules will have together on access to care because for years it's been a priority for us to move patients from institutions into home and community-based settings. And so I guess my question is, can you speak on how the 80/20 pass-through rule may undermine home and community-based services and lead to increases in utilizing institutional care like nursing homes?
Thank you, Congresswoman, for the question. It's such an important question. I think as a practical matter, the 80/20 rule will significantly increase the cost of home and community-based services and place increased demand on an already limited workforce supply. And when there are insufficient resources to be able to provide the supports that individuals need, insufficient providers, insufficient workforce, it means that individuals will have no choice but to look to the institutional benefit, which is a mandatory benefit, and therefore would be available to them. So I think it could very well have exactly the opposite effect that is intended. Add to that the fact that if the staffing rule goes into effect for nursing homes, and they are also competing to add additional staff on the nursing home side, which they already are, but it will drive up cost of those nursing facility services. Again, there's a workforce pool that everyone is sort of striving to draw from, and it will increase the demands on that workforce pool, and I'm afraid pull away from home and community-based services and into the institutional setting.
I can see how that happens. My dad is 90 years old, and they take care of him at home. With hospice, even though he has a Parkinson's issue, and it is really difficult to get people just to come in and bathe him. Or, it may be 2 times a week, or 3 times a week, and it's cut back to 2. And, that's where myself or my sister, somebody has to step in and help with that. Can you speak to what will happen if we require an enforcement of the nursing home staffing ratio at a time when there's a risk that this 80/20 rule could push more people into nursing homes?
I think there are twofold challenges. One, obviously, is that we are going to see a number of nursing homes that are not able to comply with the rule, and could, quite frankly, put nursing homes out of business in an attempt to comply with the rule, again, at a time when there will also be additional strain on the home and community-based services system and potentially fewer providers to deliver services in people's homes, and therefore an increased demand. We're seeing increased demand already because of an aging demographic.
Yes.
This will sort of be a trifecta of challenges that will be untenable.
Exactly, and I visited a number in my district nursing homes, and the staff ratio, the quality of care, honestly, they love what they do. Just like Ms. Hughes said, they will take care of those patients, and some of them have been there 20 years or more. And same way with the physicians taking care of those patients. But you've got experience, I guess, considerable experience with TennCare. That's Tennessee's Medicaid program, and most recently, the TennCare 3 demonstration that allows Tennessee to participate in savings it achieves by managing the Medicaid program well that can be invested in certain state health programs so long as these quality metrics are achieved. Can you talk briefly in 36 seconds about Tennessee's experience and successes, particularly in LTSS, and how that informs your workforce recommendations?
Thank you for the question. We've learned an awful lot about how if you let states really drive innovation, good things can be accomplished. In the first year of the TennCare 3 demonstration, there were hundreds of millions of dollars of savings that can be invested and are being invested in ways that increase access to services for people with intellectual and developmental disabilities, for maternal care, and for the first time ever, a comprehensive adult dental benefit. We have learned in long-term services and supports that there are more cost-effective ways of delivering services in the community. And a part of that really does include looking to workforce alternative solutions that allow people to both have more independence, but also allow those services to be delivered far more cost-effectively.
Well, I know I'm out of time, and I will talk more to you. Ladies, thank you for being here today.
Gentlelady yields back, and I recognize Ms. Kelly of Illinois for her 5 minutes of questioning.
Thank you so much. I represent the 2nd Congressional District of Illinois, so the Chicagoland area. I'm urban, suburban, and rural. And my office has received outreach from various stakeholders. I've heard from the American Federation of State, County, and Municipal, and I've received outreach from long-term care facilities. And I think we can all agree that we should be rewarding care work, which is physically and emotional demanding work, as we've talked about. We should be rewarding workers whose job it is to take care of our most vulnerable population. And the low wages, difficult work conditions, and increasing workloads are contributing factors to the workforce crisis we're seeing across the long-term care industry. Miss, is it Simtenka? Okay. In general, it seems like rural healthcare facilities face distinct problems, from volume issues to lack of access to advanced technologies. This country is in the midst of a workforce shortage, and this shortage is hitting rural areas especially hard. Are there federal programs that need to be reevaluated to help long-term care facilities improve the nursing workforce pipeline for rural communities?
Thank you for the question, Congresswoman. I think the data doesn't show a difference in staffing levels in long-term care facilities between rural and urban facilities. And so certainly maybe we need to look into that more closely as to why that is. But the data show that there's no meaningful difference between rural and urban facilities. I mean, certainly we need to take all of the steps that have been addressed here today with respect to focusing on the workforce, focusing in on turnover rates, focusing in on making these quality jobs to attract people into this field so that we do have a good pool of people to pull from and that will stay and work in long-term care facilities and as home care aides in order to provide services for individuals.
Thank you so much. And I want to ask Ms. Hughes, how long have you worked in the facility you work in?
14 years.
Wow, 14 years. And in your experience, how long do you see people lasting because of lack of pay or the burden of work?
Honestly, for a brand-new CNA, we are lucky if they manage to stick around for a year. Most people only last a matter of months. Sometimes it's to go to a better-paying job. Sometimes it's to stay home, or they just wash their hands of the entire idea of ever working in a nursing home again.
Thank you. And Ms. Schuman, since you said that you've improved salaries, and have you seen people stay around longer? What difference have you seen since you've done this?
Thank you, Representative, for your question. It's a challenging time in nursing homes right now. We are recovering from the pandemic. So it's a very unusual time. Currently, our nursing staffing retention rate is about 78%. We have a lot of core people that have been and served with us for many years. It is a calling, and if individuals are called to do this work and have the heart for it, they typically stay.
But do you also see CNAs, like Ms. Hughes said, leave in a matter of months, or?
Certainly. There is a burnout issue and a turnover issue. We desire more workforce. That's not a concern of ours. We do desire to have more workforce, and we would appreciate any support and assistance we could get to build back a workforce.
Thank you, and I yield back.
Gentlelady yields back. Now recognize Mr. Joyce of Pennsylvania for his 5 minutes of questioning.
Thank you, Mr. Chairman, and thank you for the witnesses for being here on an historic day, and thank you for your testimony and your work. Today's hearings puts into focus the undue burden that the Biden administration's proposed rules will place on long-term care, as well as home and community-based services. As a doctor, I know that a one-size-fits-all approach to medicine and an unrealistic top-down mandate on long-term elder and palliative care is not the solution. And the care that our nation's most vulnerable populations rely on will be gravely impacted by these proposed regulations. Just last week, my colleagues and I wrote to Secretary Becerra and voiced our opposition to the staffing rule, a proposal that would limit access to care for seniors, cause mandatory increase in state Medicaid budgets, and could most consequentially lead to widespread nursing home closures. As someone who represents a predominantly rural district, I know that recent regulations will have a disproportionate impact on my constituents and their ability to access the care in the correct setting. The idea of enhancing access to care while simultaneously depleting an already dwindling workforce via unfunded mandates will do irreparable harm to these facilities, to the workforce who staff them, but most of all, to the patients who need you each and every day. This will do nothing to advance access to high-quality care, which is all of your goal. And I think all of us on both sides of the aisle share that common goal. Ms. Schuman, in your testimony, you highlight that your own facility has recently increased wages and benefits packages. However, in face of that, you still have hiring challenges. Can you explain how this administration's proposed rule will impact your industry, your facility, and facilities that are situated in rural communities that I represent in central Pennsylvania?
Thank you, Representative, for your question. This is a very concerning proposed mandate. I am concerned, after 25 years of serving the elders in my community, that I would have to shut down based on the fines proposed, based on the mandates proposed. I am in an urban area. I am just south of Denver. I can only feel for my colleagues who are in rural areas. I know there has been a disproportionate number of rural communities that have been closed, and our studies show that up to 208,000 residents could be displaced if this mandate were imposed.
Over 200,000 patients displaced, and a disproportional impact on rural communities. This proposed rule would have severe deficits to all the work that you do. It would impose something that would be unheralded and truly unreasonable for you to expect to work through. The proposed 80-20 rule could lead to reductions in HCBS care in Medicaid by as much as 30%. The Partnership for Medicaid Home-Based Care found that over 90% of providers would face challenges in serving rural populations and would cause cuts to clinical oversight, training, and non-direct care staff. Ms. Cullo, is it fair to say that this new requirement could hurt access to care and cause providers to close or to reduce service areas?
Absolutely. It would definitely have a disproportionate impact on smaller providers, ethnic providers, who cannot meet the guidelines and be able to afford with all the other costs, administrative costs of operating these businesses.
Ms. Killingsworth, is it possible that the impacts on state budgets will actually adversely impact access to care?
Thank you for the question. Absolutely. States have limited levers available to maintain the expenditures within a state Medicaid budget. And so if additional payments are required to increase payments to providers to help ensure that they can comply with the regulations, then that would, of necessity, mean there would have to be cuts in either the populations who receive these services or the benefits that are available to them, unless states have unlimited resources to bring to the table, which they do not.
And then you're absolutely correct. Those unlimited resources are not available. You previously managed long-term care services for a state. What flexibility did you have at the state level to try to manage some of these costs?
What we did was really work with providers to try to come up with solutions that would support them with recruitment and retention efforts by bringing in expertise, by also helping them to begin to collect data to use in their workforce development efforts, and then by doing targeted rate increases that we were really doing in partnership with them that would allow them flexibility to be able to pay their workforce more.
In any sense, could you see benefits from this proposed mandate?
I think it is well-intentioned, but ill-conceived and most likely to have negative consequences.
And those negative concepts, those negative consequences are why we convened. Mr. Chairman, my time has expired and I yield.
Thank the gentleman for yielding back. Now I recognize Ms. Barragan of California for her 5 minutes of questions.
Thank you, Mr. Chair. We've heard today how the CMS proposed rules will impact the long-term care workforce and access to care for nursing home and home health patients. As a primary caregiver for my mom, this issue is deeply personal, and I recognize the need for Congress to address the unique challenges that the sectors face. Ms. Smetanka, Democrats included an increase in the federal matching rate for Medicaid home and community-based services in the House-passed Build Back Better Act. Unfortunately, this funding did not make it into the Inflation Reduction Act. Can you talk about how this investment would help home care agencies meet the worker compensation requirement in the proposed Medicaid access rule?
Additional resources certainly are necessary in home and community-based services, and expansion into the availability of those services is something that certainly we hear a lot from people. They want to stay at home. They want to receive services in a location of their choice. And frankly, there are a lot of people living in nursing homes today that could live in the community if appropriate supports were necessary for them. So by adding the resources as was proposed in the Build Back Better Act would take important steps forward in helping to provide some of those additional supports into the home and community-based services sector and increase the availability of services.
Well, thank you. You know, I just the other day got an email that there is a waiting list again for the in-home care program. I know when my mom applied for it, she was on the waiting list for 6 months. And there are people who, as you said, would rather be in their home than go into a nursing home. And we know people like my mother who have Alzheimer's, who gets the one-on-one attention at home, would not get that into a nursing home. And the decline would be much quicker and much faster. So I see firsthand the importance of that funding, and I see the difference in families who have that ability to be able to stay in their home. I want to follow up with you. California recently passed a minimum wage increase for healthcare workers. Give us your thoughts. Will a higher minimum wage attract new workers for both home health agencies and long-term care facilities, given we hear about the shortage?
Higher minimum wage and increased wages is one of the factors that will help attract people to this field. And so by having an increased minimum wage, that would help benefit bringing people into this area and want to work more in these facilities.
Great, thank you. Ms. Hughes, nursing homes with a high share of Hispanic or Black residents had higher rates of death during the COVID-19 pandemic. While patients of color are more likely to have pre-existing conditions that put them at higher risk, they're also more likely to be in facilities that are chronically understaffed. Studies have shown that higher staffing is closely tied to higher quality of care and fewer COVID-19 related deaths. How can the minimum staffing standards proposed by CMS address health disparities and improve quality of care for patients that are maybe minorities or of color?
Thank you for that question. I think that setting a federal minimum floor that you can't go below would do a lot to fix this problem. The quality of care that you receive wouldn't be based on your zip code anymore. And I think that that speaks to the point you were trying to make. If you live in an area that is poor, that doesn't have good Medicaid reimbursement rates, and you work in a long-term care setting, there's going to be less money available to go to wages to pay for workers. Setting this floor will go a long way to fixing that.
So Democrats have continuously fought for funding to provide training and increased compensation for healthcare workers, Ms. Hughes. With the minimum staffing proposed rule, CMS announced a campaign to support staffing in nursing, including $75 million in financial incentives through scholarships and tuition reimbursement. How would this type of funding help facilities meet the proposed staffing rules or requirements?
I hope that it would help at all. I work in a town where the largest employer is a university. We have a large population of students, and I see plenty of them come through and choose not to stay. With increases in wages and maybe loan forgiveness, more of them may come in and actually stay and look at it as a good job and a real career.
Great, thank you. With that, my time has expired, and I yield back.
Gentlelady yields back. Now recognize Ms. Miller Meeks of Iowa for her 5 minutes of questioning.
Thank you, Mr. Chairman, and I thank you to the witnesses for testifying before the subcommittee today. Unlike probably most members of our august committee, I actually volunteered in nursing homes, volunteered in mental health hospitals, was a student nurse prior to becoming a nurse, then continued to do nursing while I was putting myself through medical school. So it's an issue I might know just a little bit about. My district that I serve in Iowa also happens to be a rural district, although we have urban areas as well. CMS's recent Medicaid access rule included a proposal that would require states to spend at least 80% of all Medicaid home and community-based service dollars on direct care workers. Many states have expressed concern with this rule, primarily with CMS's decision not to permit exceptions to the 80% threshold. This will likely impact two groups: small and new providers compared to large established providers, and rural and frontier providers who often have fewer options to optimize administrative costs and higher cost of recruiting and maintaining staff. This is a major concern for rural states like Iowa. CMS might want to consider alternative approaches, such as scaling threshold based on provider size, rural-urban status, risk of closure, and/or an exceptions process for small providers. Of course, not all entities would utilize this process, but offering flexibilities to account for the geographic differences and challenges associated with those differences would make sense. And I know this personally, having cared for my mother with Alzheimer's, who was in Oklahoma, and I was in Iowa. And she lived with us for a year before going back to Oklahoma. As the chair of the subcommittee for Veterans Committee, I also want to focus my concern not only on what I think the impact will be for Iowan seniors and people with disabilities who depend on Medicaid home-based services, but also our veterans who are increasingly relying on home-based long-term care. A 2020 GAO report indicated that there is significant growth in veterans receiving home care and other home-based services. While veterans can receive this care through the VA benefit, many also receive home care services through Medicaid home and community-based service waivers. Regardless of the payer, the providers that are being targeted by the Medicaid access rules payment proposal serve both our broader population and veterans. Ms. Killau, given already limited provider resources in Iowa, I'm concerned about what the Medicaid access rules impact will be on provider networks,
to meet current and future needs of Iowans, including veterans. Can you talk a bit about how implementing this rule could affect the home care provider network overall, and what happens when individuals cannot receive home-based care?
Thank you for the question, Representative. You touched on it. First of all, you know exactly what the issue is. If they do not have the adequate, first of all, rates to pay, they need the funding. If the 80% rule goes through as written, that means providers will close or they will not open up, and we need the expansion to deal with the growing population. And so we will have issues, and clients will not be able to receive care ultimately and maybe turn to a nursing home setting.
Which is much higher cost.
Absolutely.
Ms. Schuman, to meet the proposed staffing levels, nursing facilities would need to hire an additional 1,417 direct care staff or reduce resident count by 2,559, or 13% in Iowa. However, such workers are not readily available, and that's regardless of pay. And recruiting and retaining them would significantly drive up costs for all healthcare providers. I will also note that 17 nursing facilities in Iowa closed in 2022, 15 of which were in rural communities. Can you please discuss the impact of the current healthcare workforce deficit and how the proposed staffing ratio would influence that impact, not only in the nursing home setting, but across the care continuum?
Thank you, Representative. I think you mentioned it well, that it would drive up costs. And currently in my state, we had a proposed Medicaid rate to go in effective July 1st, and we have yet to receive the dollars from that because the proposal and the approval is on CMS's desk waiting for approval. It's a very complex system and a very complex process. Access to care will become an issue. People will either have to limit the admissions into their communities or they will shut down. And as you mentioned, rural communities are disproportionately impacted, and underserved communities are also disproportionately impacted.
Dr. Miller makes yields back. The chair recognizes Dr. Bouchon for 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate the opportunity today to discuss proposals by the Biden administration to implement staffing ratios and other requirements at nursing homes across the country. I was a physician before I was in Congress, cardiac surgeon, and I understand how crucial it is that we provide patients access to quality health care. I recognize that facilities can only provide quality care if they have quality staff, and I have no doubt that most facilities would benefit from additional set of hands. But this has been a chronic problem for a long time. Here's the problem. Our healthcare system is facing a critical nursing shortage. So it's a rock and a hard place here with this rule. Even prior to COVID, projections suggested an impending national shortage of RNs, and things only got worse during the pandemic. My home state of Indiana has about 44,300 job openings for nurses as we speak every year, and is currently projected to need an additional 5,000 nurses by 2031. That's before any of these staffing ratio proposals are implemented. But rather than focusing on growing a sustainable workforce, the administration has passed down a staffing mandate which could force facilities to cut services or shut down entirely. When they are unable to comply, there's just nobody out there to hire. This would leave patients and their families hanging in the balance, particularly in rural areas like the one that I serve, the district I serve. Ms. Hughes, I have to agree with the statements in your testimony that it's beyond frustrating when people who sit behind a desk all day dictate staffing needs. But that's exactly what happened when CMS issued these proposals. This staffing mandate will exacerbate rather than alleviate existing staffing challenges. Providers in Indiana and throughout the United States will be unable to meet the staffing requirement, which will threaten patient access to care. Again, there's a nursing shortage. I described how short we are in Indiana. I think all of us want to provide, as much care and for the safety and medical care of our clients, our patients. But a top-down mandate isn't the way to go. Many of you have described this workforce challenge. Ms. Schuman, have you been successful at offering career opportunities like helping current nurse aides train and become RNs? And would your ability to do this change under the rule?
Thank you for your question, Representative. We've had great success with a lot of our certified nursing assistants going on to become LPNs. LPNs, licensed practical nurses, go on to become registered nurses. One of our greatest challenges, though, is training our CNAs. In the state of Colorado, about 60% of providers lost the ability to train CNAs due to civil monetary penalties imposed in the state during the survey process. In addition to that, some of our staff have to travel 4 hours to test to become certified in the state of Colorado. This is extremely discouraging considering our workforce is predominantly made of women and women with children.
Yeah, it's a huge challenge. Do you work with some of your educational institutions in the state to try to have that pipeline? And with that question, how's the competition for those people who are graduating? It's pretty tough, right?
Yes, thank you for your question. The educators are part of a healthcare collaborative with providers, and there are more individuals interested in becoming nurses than there are places for them in the educational institutions.
Yep.
It is very competitive to hire a nurse.
Same thing's true in Indiana, by the way. We have statewide junior college system, Ivy Tech, and we also have educational institutions, even four-year ones and we still have chronic shortages. Ms. Killingsworth, in your testimony, you mentioned you're over 25 years of experience at the state Medicaid level. From a statewide perspective, do you believe that it is the most efficient distribution of resources to require RN care at the level proposed in the rule in all nursing homes?
I think as a practical matter, there are not enough nurses to be able to meet that staffing ratio requirement, especially when you take into account the totality of the healthcare.
But say hypothetically you did, would that be the best way you would use extra resources? Or is that a most efficient way to get patient care to your patients, you think?
I think that states need flexibility, and quite frankly, providers need flexibility to be able to target their staffing levels to the needs of the residents that they serve.
Agreed. That's my position. My position would be you need flexibility to decide what's the best way to take care of your clients, and a top-down rule is not what you need. I yield back.
Thank you, Dr. Bashan yields back. Dr. Shaw, you're recognized for 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to our witnesses for being here today. Thank you especially for coming out from Washington State, Ms. Hughes. In my district in Washington State and all across the country, we continue to face a severe shortage of healthcare workers that directly impacts patient care. When nursing homes and long-term care facilities don't have the staff or the beds available for patients in need, it leads to long wait times for seniors who then get stuck in hospitals, and then those beds are not available for other patients who might need them. There's a whole cascading effect. And so ensuring that we have the workforce that meets the needs of our growing senior population is critical. Now, Washington State already has some of the most expansive staffing requirements of any state. They include some key differences from the CMS proposals, and an analysis from the Kaiser Family Foundation found that just under half of Washington nursing facilities, 49%, would currently meet the required RN and nurse aide minimum standards. So our state is already trying to address some of these concerns around proper staffing levels and adequate patient care, and it remains a challenge. So that's why I wanted to focus today on really capitalizing on opportunities to bring workers into the industry and to ensure that those workers have path for professional growth and family wage jobs and advancement. And I'm really glad to see funding included in the rule for training nurse aides to address the shortage, but I believe that more complex and significant efforts are also necessary. Ms. Schuman, first question is for you. Could you share what hiring and recruitment efforts look like for your facilities? What are the recurring challenges? How long do people stay? And are you meeting your requirements?
Sure, thank you for the question. It is a challenge to recruit for sure. One of our individuals in our community spends most of her time just trying to recruit staff. And I would say maybe 2 applicants apply, And out of those interviews, maybe one stays. And so these are for a lot of open positions. There are not people applying. There are not people even wanting to start a first day. So the people just absolutely are not there.
And we hear those things from other employers as well. And I would say that this particular line of work is a very difficult, challenging line of work. And when the pay does not match the skills and love and care required to do that job, people will look elsewhere. Ms. Hughes, thank you for being here and speaking directly to the experience of CNAs in Washington. In your testimony, you mentioned the downward spiral that low staffing levels lead to, especially when it comes to staff retention. And I was wondering how the federal government can be better at addressing the recruitment and hiring needs of these facilities in order to grow the pipeline of nursing staff who will take care of our loved ones.
I think that definitely reaching out to local community colleges, reaching out to people that are in my union, and making sure that, you know, everyone who wants a union has a pathway and a right to get to one. When I talk to these, you know, younger caregivers out there, they are full of so much passion and drive, but they are not willing to put up with poor conditions on the job.
Understandable.
Yes, absolutely.
And our state has been leading in unionizing, and I know it's not directly applicable here, but home health care workers have a union in Washington state. With the growing number of seniors who will need long-term care services and supports, we have to find creative solutions to meet those demands with the existing infrastructure. And home health care is one of the solutions, keeping people in their homes as long as possible to get that care and not overload nursing homes. And I was wondering, Ms. Killa, did I say that correctly? How can home health care help to ease the burden on nursing homes and long-term care facilities?
Well, we have the certain same nursing home level of care need for people to stay in their homes, and they want to live in their home. So it gives them choice, and it gives them the ability to live in their home with dignity and provide that assistance. So without adequate workforce, that would not be available to them.
And I am out of time, but perhaps you could submit an answer to the question of financially and logistically, which becomes a more affordable and sensible option on a broad scale. Thank you for...
We'll be happy to. Thank you.
Thank you. I yield back.
Thank you. The gentlelady, doctor yields back. The chair will recognize Mr. Griffith for 5 minutes for questions.
Thank you very much, Mr. Chairman. I want to thank all of you for being here today. This is an important issue, and while I don't think that the current rule will help matters, I think it will make it worse. That being said, we have to work together, as I believe the ranking member said, to find out solutions. This is not just about bashing one administration or another. It's about trying to find answers together. So I'm going to start with you, Ms. Killo. In your testimony, you cite that the Clinton administration filed a brief in a Ninth Circuit court case regarding state Medicaid agencies and payment rates. That brief submitted by the Solicitor General claims that the purpose of Section 1902A30A of the Social Security Act was to give states wide discretion to set Medicaid payments that are consistent with efficiency, economy, and access to quality care, and that the Secretary does not dictate what level of payments would be sufficient to provide for equal access to such care and services, nor does the Secretary require the states to adopt any particular procedure or methodology for determining whether payments are necessary to meet the general criteria in the statute. All that was a quote. Now, Section 1902A30A, also known as, you know, they always confuse you. You got the code section, and then you have the statutory section that are not always the same, but it's the same section of the law, 42 U.S.C. 1396A, 30A, states that state Medicaid plans must ensure that provider payments are, quote, consistent with efficiency, economy, and quality of care, and are sufficient to enlist enough providers, end quote. Do you think what CMS is doing with these rules or with this rule violates what the law states and what the law intends? Putting your lawyer hat on.
Absolutely. There nothing in what CMS is doing is going to allow for making sure states have the discretion to provide that.
Right. And as many have said, the intent may be good, or what they're trying to do, because we need more workers. As Dr. Bouchon pointed out, we need more people getting their RNs. We need to go forward. We also need to look at other things. I was really intrigued with your testimony, Ms. Killingsworth, on technology and using technology and maybe trying to look outside the box. And that triggered, even though I have a whole list of questions here that we worked on ahead of time, it triggered a thought in my mind. And so I went and got them to pull out one of the last code sections I ever got when I was a member of the Virginia House of Delegates was to change zoning laws in Virginia so that we could put temporary family health care structures on property. So we waived all the zoning laws. If you meet the criteria and you've got somebody that needs help and you want to put, I hate to say it, but the Washington Post dubbed it as a granny pod, but it's a medical health facility, basically a small home in the back on your lot, waived all the local zoning rules if you're meeting this, and it has to be there temporarily. You can't leave it there permanently. Do you think something like that would help in alleviating some of the concerns? Because you can be with family members, as Ms. Barragon was saying, she's giving care to one of her parents who's got some Alzheimer issues. Do you think that might be helpful as one of the ways to figure out things outside the box as opposed to putting strict requirements on 80-20 for, 80% of the money coming from Medicaid has to go to the worker?
Thank you so much for the question. I do think there's a range of technologies, including the one that you spoke about, that would provide access to more cost-effective ways of supporting people where family caregivers can be involved, and you can leverage technology to also provide some of the supports that individuals need, and then really target those limited workforce resources in ways that better use those resources as well as the overall program resources.
And Ms. Killo, and this may not be your field, so just say so if it isn't, but does the rules currently allow for any reimbursement for such a structure to be placed in the backyard of somebody's home?
I don't believe so, but it brings to mind that creativity is placed within states to have the opportunity to build such programs, and they should be given the freedom to do so.
Yeah, I had less than 10% of the people that I have now that I represent in a much smaller area, and somebody just walked into my office one day and said, I got this idea. And the next thing you know, it's the law. Ms. Smetanka, what do you think? Is this something that would help?
Well, I mean, I certainly think that we should look at whole range of solutions and creative solutions to meeting the care needs for our individuals. But we need some basic care levels and basic standards.
Wouldn't it help if there was a little bit of Medicaid money that would help people stay at least with their loved ones, even if they have to be put into a facility that's just outside the back door?
Certainly, we need to look at how Medicaid dollars are currently being spent right now and look at how they can actually meet the
Figure out how we can use the same money more creatively. And I will say, Mr. Chairman, I know I'm over time, but one of the things I thought about at the time was I had small children, and if I had a stroke or something, I wouldn't want to be in a nursing facility, while many of them provide great things, but I'd want to be able to be there so that one of my sons or my stepdaughter could bring in that treasure they found in the backyard and show it to me. And so it's not just for the elderly, it's also for people that may have had something debilitating like that. I yield back.
Thank you. The gentleman yields back. Chair recognizes Mr. Carter for 5 minutes for question.
Thank you, Mr. Chairman, and thank all of you for being here. I don't know this for certain, but I suspect that there's not another member of Congress who has the experience that I have in nursing homes. You see, I was a consultant pharmacist in nursing homes, so I spent hours on end in nurses' stations, going over patients' chart, making drug recommendations for those patients. And I've witnessed firsthand the work. Ms. Hughes, you mentioned, you told stories about CNAs. I was there at night, I was there on the weekends. I saw what great value you bring in CNNs and CNAs and LPNs, and I don't understand why they're left out of this. That baffles me, but I just want you to know how much I appreciate the work that you do. This is more than just work. This is a calling. And just as I feel like I've been called to serve here in Congress, I feel like people who work in nursing homes, it's more than just the money. And money's important. There's no question about that. But it is extremely important. And you know, Ms. Hughes, you mentioned about good days and bad days. And I can take it one step further. I've seen nursing homes, I'd walk in the morning and they'd be great, clean and everything's great in just a couple of hours. When you've got that many people together, particularly this patient population, it could just fall apart. And all of a sudden, there's just, the smell of urine throughout the facility and just trash everywhere. And it's not anyone's fault. It's just the way that it is in the nursing home situation. So again, I want you to know how much I appreciate it. Ms. Schumann, you said that these are compassionate and selfless people, and you're right, they are. And they deserve this. What they do for these patients is extremely important. You also mentioned, Ms. Schumann, some of the things that we might be able to do, like student loan forgiveness, in order to attract attract people to the facilities and employees. And I wanted you to elaborate on some of the things you feel like we can do to get more people involved in this, because it really is a calling and really is necessary.
Thank you, Representative, for your question. Yes, student loan forgiveness would be amazing. The cost of becoming a licensed practical nurse or a registered nurse is astronomical. Pass-through tax credits that go to individuals who choose to work in our profession would go directly to them on their tax returns would be amazing. I just also want to point out that currently there are over thousands of foreign-born nurses who have the appropriate visas to enter the country, who have not yet been interviewed to enter the country. That would provide us immediate relief as well.
That's great. Thank you for mentioning that as well. Ms. Hughes, do you have any idea, any suggestions on what we could do to attract more people into this? I mean, look, this is, when you say selfless, this is selfless. I mean, I've seen it. I've been there hours on end, and I know what you do, and I don't know what it would take, to attract more people to doing this type of work.
Well, when it comes to the credentials, maybe having portable credentials. People come from out of state who've been doing this job forever, but essentially have to start all over, take the class, take the certification test to be able to walk into a nursing home and do the work that they've been doing for 20 years.
Sure.
So,
sure.
Making that a little bit easier would go a long way. But just doing whatever we can to improve the conditions in the home. The number one thing that I hear from people is that, they're being given too many residents at a given time to do a good job.
Well, I want you to know that I think that these policies that are being promulgated here and being proposed are horrible. This is going to lead to nursing homes closing. In fact, almost 80% of facilities would be forced to close if this went through. And that shows you just the tone deafness of HHS and CMS in trying to propose something like this. They have no clue as to what I've seen and witnessed in my years of practice as a consultant pharmacist and the work that you do. And this is I've been in touch with the Georgia Nursing Home Association. They've already expressed to me their concern about this and how it's going to be devastating to the nursing homes. And where will these people go? Where are they going to go? I mean, the number one reason that a lot of them are in nursing homes to begin with is medication administration, because they need help in administering their medications and getting there properly like they should be. So that is something that we have to keep in mind as well. But I'm glad I had the opportunity to ask you questions and to be able to speak to you, because I want you to know how much I appreciate everything that y'all do. This is truly something that I have for years admired, and thank you all for being here today. And I yield back, Mr.
Thank you. The gentleman yields back. The chair recognizes Mr. Crenshaw for 5 minutes for questions.
Thank you, Mr. Chairman, for holding this hearing. I think it's worth noting we all agree that there's a serious problem in workforce shortages, and that our nurses work an impossible job, and especially in these long-term care facilities. It's an extremely difficult job, so it's no wonder that's extremely difficult to find the people who want to do it. But I'm surprised anyone thinks that this solution would somehow create more of these wonderful people that we need so much of. You can create a mandate to create more nurses. It doesn't mean we can write a law that says there'll be 75,000 more nurses. It will not create 75,000 more nurses. It's just not how laws work, and it's not how nurses work. It's not how a labor market works. They don't just arrive. And there's a strange kind of philosophical assumption with a mandate it assumes that nursing homes are purposefully not hiring nurses. That is the factual assumption being made when you're offering a mandate. You're saying you are not hiring nurses and you should be. Okay, is that, who owns a nursing home? Is that true?
We desire to hire more nurses, Representative.
Okay, so you already desire to hire more nurses. They're not there. What if you, I mean, could you what's a reasonable amount you could raise your salaries to, and they still, would it make them exist?
No, not under the current reimbursement system. We could not raise them to.
Yeah. So these are just facts of economics. Like the people just aren't there. So these are economic facts, and it's important to note that we're bypassing basic factual analysis. Okay. But we do agree that there's a problem and that we want better care. We want nurses not to be burned out, and the only way to really do that is to have more of them. And so there's a bunch of solutions we should be talking about to do just that. Ms. Schuman, I'm really, so that's the mandate on nurses. Then there's this other interesting rule on the 80-20 rule. I am dying to understand how that would even be implemented, and it's a complex business. Any nursing, any facility is a very complex business. This 80-20 rule, how would that be implemented? Do you guys have any idea?
So I am a skilled nursing provider, not a home health provider. So fortunately, that's not one of the issues we're dealing with. We are dealing with the workforce shortage, and we are requesting collaboration to help build back the workforce.
Maybe you could, yeah.
I'll be happy to answer that because I don't know how it would be implemented. First of all, it doesn't give guidelines on implementation. It would fall upon the states to come up with how they would collect that data. And it doesn't really describe what the 80% or the 20% would consist of, or what you can count towards the 80%. So it'd be very difficult to implement.
Any background on where 80-20 even came from? Was it just arbitrary? What happens if you're 75-25? Like, are you put out of business? Any guidance from CMS on that?
No, it was really unclear where the 80% came from. I know there were some states, ours being one of them, in Illinois, that has a 77%, but there's no guidelines on where the 80% came from and exactly what would be covered under that 80%. They have some items listed, but not everything that is included in that we pay out for direct care workforce.
Yeah, it feels very arbitrary, you know, and I don't know whose great idea Ferry was flying around at the time. But these are complex issues that require, I think, a little bit more analytical thinking. Back to Ms. Schuman, I mean, to comply with the mandates, how much staff would you actually need to hire to comply? And how does that compare to your hiring rate currently?
Sure. So unfortunately, one of the challenges with the staffing mandate, it views everything on a daily basis. We deal with a lot of women who have children who may have to call out because their children are sick. And so if I have an RN who has to call out and I cannot get coverage for her shift or his shift because their child is sick, then I would be out of compliance with this mandate. So being able to, it is nearly impossible to be able to meet the standards right now, even if, unless I were able to get an increased rate, a daily rate, and hire more and more and more RNs and have maybe 5 on staff for a shift to mitigate any type of call-off. I don't know how I would.
And we're seeing these estimates that 300,000 residents could be expelled from nursing homes as a result of this. Does anyone dispute that number? And that's a real big deal. Well, I'm out of time, but sorry.
Gentleman yields back. The chair now recognizes Mr. Bilirakis for 5 minutes.
Thank you. I appreciate it very much. Thanks, Mr. Chairman. I want to thank the ranking member as well for holding this important hearing to shed light on these 2 disastrous proposals, these rules by this administration that would threaten access to long-term care services for millions of Americans and seniors in nursing homes, particularly in my state of Florida. Unfortunately, those in my state know this all too well, as this is yet another attempt by the administration to federalize the Medicaid program to a one-size-fits-all to the detriment of patients. And again, we think outside the box, and it's working really well, that flexibility in the state of Florida. Thankfully, Republicans on this committee are committed to holding CMS accountable for their Medicaid access rule, which would have damaging impacts on home and community-based services, has been pointed out all afternoon. It's been pointed out. And leadership in Florida has also led the way in this effort. Our state agency for the Healthcare Administration Secretary, Jason Wyda, sent comments regarding the proposed 80-20 rule to CMS, stating that it would be unduly burdensome, especially considering that Florida statutorily requires HCBS providers to pay their direct care workers $15 an hour. And ultimately, that's the minimum wage in Florida, $15 an hour. And ultimately, the rule circumvents the legislative process and prohibits states from administering their Medicaid programs, which is their lawful right and duty, in my opinion. So first question is for Ms. Killingsworth, and forgive my voice. As you know, we already have workforce challenges and significant shortages among the LTSS staff nationwide. Even if these regulations were to work and resolve the shortages, which we both know they will only make the problem worse, in my opinion at least, we would still be experiencing shortages in the short term regardless. So can you tell us what can states and health plans do now to help support patients when there's a shortage of workers, and there is in home and community-based settings? So I know this is a real issue, particularly in my state of Florida, where we have a lot of seniors. So if you could answer that question, I'd appreciate it.
Thank you, Congressman, for the question. It's a really important question because one thing that we saw during COVID was lots of people who struggled to have access to the care that they needed. And one of the things that we learned during COVID is that there are alternative ways, oftentimes, of providing supports to people in order to meet those needs. Earlier, it was mentioned that one of the primary reasons people go into nursing homes is because of medication administration, and yet across the market, there are an array of very simple to incredibly complex medication management systems that allow people who have issues with medication to be able to manage those medications safely at home. And that could well mean the difference between whether someone is able to stay at home safely or go into a nursing home. That's just one example of a continuum of assistive devices that are now available to people that weren't available a couple of decades ago, that will never fully replace the need for in-person assistance, but oftentimes can give people back tremendous levels of independence in their lives, and then really be able to target that workforce much more efficiently.
It's a good example. I appreciate it. I know there are many examples when you think outside the box, like Florida does. So, Ms. Killow, do you agree with what Ms. Killingsworth said, and can you elaborate on these thoughts? Beyond getting rid of this harmful 80-20 requirement, what are things that we can do instead to help support the HCBS workforce now rather than worsen things? And again, if we put our heads together, we can come up with creative ways. I know there's a path there. So if you could answer that question, do you agree with Mrs. Kellogg?
Yes, I absolutely agree with her. And I do think we have to think outside the box. Again, during the pandemic, it forced us to think outside the box, and we were able to do a lot of things with some additional allowances from CMS at that time. I also believe recognizing legally responsible individuals to work, family members to help work for this workforce. They were excluded and unable to work except for during the pandemic. I know we're requesting that in our state waiver. But allowing those individuals to be paid and worked in the home will help assist this shortage also.
Absolutely, and it'll save money in the long run as well. So yes. We appreciate, but again, increasing the loved one's quality of life, so very important. Thank you. I yield back.
The gentleman yields back. That concludes all members of the subcommittee, so we're now going to move to waive on. So we have members of the full committee that have waived on. Mr. Duncan, you're now recognized for 5 minutes for questions. Thanks for your patience and participating in the hearing.
Thank you, Mr. Chairman. And as you ladies heard, I'm not even on this subcommittee. This is an important issue to me because I have nursing homes and long care facilities in my district. signed on to a letter October 20th to Secretary Becerra. And in there's a labor statistic from the Bureau of Labor Statistics. Quote, there are roughly 235,900 fewer healthcare staff working in nursing homes and other long-term care facilities compared to March of 2020. Just put that in perspective. That's more than the whole economy. Every manufacturing facility, every small business, that's more than the whole economy added in 7 of the last 12 months. It's a lot of people. And we've heard today the amount of training necessary for CNAs and LPNs and RNs and all the folks that are needed to work in this industry. Once again, though, we see the Biden administration weaponizing HHS and CMS and choosing politics and labor unions over providers and patients to continue their crippling and burdensome regulations, and that's what it is to the long-term care facility business. Their new victim is our nation's seniors and those with disabilities. I've spoken to constituents in my district who operate long-term care facilities, and they've expressed hardships that they have not only faced from global pandemic, but also trying to comply with overregulation. When I was running for Congress, I visited with one of them. They showed me a binder that was about like this that 10 years earlier, the regulations they had to comply with. Then he pulled out in 2010 a number of binders, probably stacked this high if I remember right, of regulations that they had to comply with at that point. So these facilities offer critical care for our seniors. They offer ease of travel for families to be near their loved ones because of where they're located, especially in rural areas like mine. But because of unfunded staffing mandates for these facilities, they're at risk of closing those facilities, closing their doors, and leaving our most vulnerable with very limited options. Hundreds of people unemployed, thousands of people unemployed, and families facing with what to do next with both their loved ones that are at the senior level that need that care, but also those with disabilities. So I want to thank you all for being here. It's been an interesting hearing. I've tried to listen and take in that information. My question is for Ms. Schuman. Are there ratios that long-term care facilities have to comply with, the number of CNAs for the number of patients, or number of maybe higher than CNA, RN, LPNs to the number of patients in the facility?
So currently, our state does have a mandate of 2.0, and also there's sufficient staffing. What this does is that's the federal mandate, sufficient staffing. What that does is it allows for individualization of the staffing patterns you may need.
Let me ask, if the facility doesn't meet that ratio, what happens when CMS comes in, or CMS's inspectors, whether it's regional or local DHEC in South Carolina, comes in and inspects? What happens?
The proposed mandate would implement fines.
Current mandate implements fines, correct?
The current state mandate, you would receive a state citation.
They get a ding.
Yeah, but
or citations end up adding up to more fines later.
If the state surveyors decided that you did not have sufficient staffing levels, you would be cited for sufficient staffing levels. Yes.
And a lot of times these long-term care facilities, Mr. Chairman, end up paying the fine versus fighting it. It's almost extortion by CMS. But how are long-term care facilities, Ms. Schuman, supposed to comply with this type of requirement when the workforce isn't available? This question's been asked numerous times. CMS has no vehicle to fund this mandate. How are you going to comply?
I am very concerned that myself and a lot of my other providers will not be able to meet this mandate, and we will be forced to shut down.
How long is the training for a CNA?
In our community, when we offer CNA classes, it's 2 weeks of classroom plus a week of clinicals, and then they shadow on providing direct care with another care worker.
For how long do they shadow?
It's typically about currently 4 months, and that's about how long it takes for them to be licensed within the state of Colorado. In the past, they could become licensed sooner. We visit with them if they need more support before they worked on their own.
Registered nursing programs are 4 years, and then they have clinical on top of that?
So an RN, you can get an associate's RN in 2 years. You can get a bachelor's RN in 4 years.
Mr. Chairman, it's obvious with the shortages that we talked about, the shortages we pointed to in the letter to Chairman Bercia, Secretary Bercia, and Becerra, and what we've heard here today, there's a huge labor shortage. Thank you for having this hearing. Thanks to the witnesses for pointing out the challenges they face. I know the nurses and the CNAs and everybody who works in this want better hours. They want better pay. But how do you do that when facilities are looking to close their doors if they have to comply with these very costly mandates? So thanks for letting me go over, and with that, I yield back.
Thank you. Thank you. The gentleman yields back. The ranking member has asked for 2 minutes to close.
Thank you. Thank you, Mr. Chairman. I think it's...
Consent to let you do it. I didn't object.
You're going to object?
I'm not going to object. I'm joking.
No, you wouldn't object. You're too nice. I want to thank the witnesses again. This has been a long afternoon, and you had to deal with the anxiety of whether this hearing would actually take place. You know, witnesses are very, very important to us in our work, and your testimony today is so important for the record and the patience of the people that are here in the audience. I think that because there's something that has been repeated over and over and over and over again today, and we have shortages in just about everything in the country today. It's not the only, but that's not an excuse. But this is an issue that has been around as far back as 1986, where the National Academy of Medicine called for a minimum staffing standard. 1986. 1999, Senate Special Committee of Aging led a series of hearings on the need for the increase of staffing that led to the 2001 CMS report. That was 1999. That's a quarter, 2.5 decades ago, or almost 2.5 decades ago. In 2022, the National Academies again call for an increase of staffing in our country. There was a 10% increase to the HCBS in the American Rescue Plan. My Republican colleagues all voted against it. I know that during the previous administration, there was massive deregulation of the nursing home industry, including eliminating infection control. One of the members mentioned walking into a nursing home and the smell of urine. Well, you know what? If you don't have enough people taking care of the people that we all say we love, we admire, they've given so much, their lives are a story, each one, a beautiful story of the contributions they've made to our country. This is not to damn an industry. This is about improving things. So this is not new. We're talking about this, woe is us in 2023, 1986, 1999, 2022, legislation to help address this and severe deregulation, and this is where we are. I'm not suggesting that this is an easy thing, that snap fingers and this is going to be resolved. But, you know, I really believe that, that the issue, and I said in my opening, let's not, I hope this is more than bashing the administration. You know, that may do something for someone in the short term. It does not help the people that are doing the work in nursing homes and the patients. So I hope that that we can add to the record that either in 2023 or 2024, the Congress of the United States, led by this committee, finally stepped up. And I'm convinced that unless and until we do, it's going to be an even longer list of of decades that we have the same issue, the same challenges, the same problems left unaddressed. So I appreciate your patience, especially since you don't agree with probably 90% of what I said. But you are a gentleman, Mr. Chairman, and I thank you and I yield back.
Thank you, Yoba. Well, you know, we agree on our families. These are our family members. I just went through this process just recently. Unfortunately, just lost my mother-in-law, but to this process, and you want it to be safe. I mean, we all want it to be safe and the best quality. And workers like Ms. Hughes that they get to experience, that want to be there and want to take care of them. I can tell the way you talked about your work. You love the job that you do. You just want it to be an area where you can be successful, and that's what we all agree with that. And so the question that we went through was just affordability, and then accessibility. We had something happen really quick with my mother-in-law, and we just didn't know what we were going to be able to do, and started looking into it. Fortunately, we were able to take care of her at home, but that was a tough situation with my sister-in-law and her husband. But we just couldn't find a spot. It was just difficult. They were in North Alabama, that's where my wife's from, and they had a difficult time doing it. So we want is the best we can have. We also want it to be accessible and have places for them to go and make it affordable. And we want to create more CNAs. We want to create more LPNs and more registered nurses. And as we have a program to do that, and a bill that I have, we have I'm telling you, the issue is, I know that you have private pay, or you have Medicaid. And so Medicaid doesn't reimburse enough to pay the wages that you probably need. You know, other healthcare providers get people with health insurance and there's a big subsidies in health insurance now. So, you know, the cost keeps going up. And so when they need more nurses, they hire a temporary nursing station, they come in and they do it. But when you're trying to keep it, because most people pay out of pocket, or they pay Medicaid. And so there's not a lot of insurance that covers long-term. There is available, I get some products, but not much. And so it's just something we need to balance. But having the balanced opinion here today is important, and for us to hear it all is important. And I don't disagree with everything that she says. We've just got to find the right balance. So we can have it accessible, affordable, and safe, and have a workforce that can be successful. Not just the employees, not just the residents, but the employees to be successful. And you represented it well, Ms. Hughes. Appreciate that. Thank you all for being here. I know you are ready for a break too. It's getting warm in here, isn't it? But I'm sorry I was going to apologize. Sorry for the way the day has gone. It's not history we want to make, but it is absolutely a historic day to have a new speaker in the middle of a legislative session. So at least you can hopefully get solace that you are here all day, but you benefited from, you were able to see that or be part of it, I guess, for the small consolation. So we have a record that you've seen the list I ask unanimous consent to insert the record documents included on the staff hearing document list. Without objection, so ordered. And again, so members will be able to submit questions in writing because not a lot, because of what was going on, got to ask the questions they would like. So I remind members that they have 10 days to submit questions for the record, and I ask that the witnesses will reply promptly. Members should submit their questions by the close of business November the 8th. Again, thank you for your patience. Thank you for your testimony. Thank you for what you do. Thank you, and without objection, the subcommittee is adjourned. Thank you. Thanks.